Good morning, everyone. Good morning. Good morning this morning. I hope we slept very well. Yes, stronger than yesterday. We thank God. So, the people sitting on this side of the hall, please, from the control room, I am told that their video for video coverage, and they would like that everybody stays at the center. So please, I plead with us. Let's cooperate with them so that we make their work easy as well. So please, let's come to the center here. What we can do, we can bring extensions. I think there should be extensions now that you plug and extend to that side. So please, since they are requesting for that, it's a gentle request. Please, let's help grant it. Thank you. All right, so everybody, we are asked to maintain the center. Also, people at that end, participants at that, okay, yeah, registration is ongoing there. No, it's okay. Yeah. So every other participant, apart from those handling registration, please let's maintain this center. Thank you so much.
All right. Good morning, everyone. Good morning, everyone. How was our night? All right. So we'll be starting today's session right about now. So please, I want us to settle down. For those of us who are still finding places to sit, please let's get set as we begin today. All right. So starting with us today, at least before we start today, so we want to have a bit of a recap of what was done yesterday. So a bit of recap of what was done yesterday. So we can, from that point, we can start what we want to do today. So giving us a recap of what we had yesterday. So I'll be calling on Miss Olorunfemi Ronke to come and give us a recap. Yes, you're welcome. Let's put our hands together for her as she comes forward.
Okay, good morning, everyone. So I'm going to be taking recap of. I'm going to be taking the recap of what we did yesterday. So yesterday was the first day for this ceremony, for this symposium. So we had opening ceremony by Professor E.A. Bakare, giving us the overview of Icammda. So where we have the overview of Icammda and what Icammda can offer us in terms of the PhDs and the masters that have been trained and the visiting scholars in the center. So then we have the Dean Faculty of Science, duly represented by the Vice Dean in the person of Dr. A.M. Seamiu, that he welcomed us, powerfully to this program. And then the HOD of departments also graced the occasion yesterday by welcoming us and make us to realize the importance of mathematics and computer science to solve real world problems. So, and then after that, Mr. Shio came up to take us mathematical model developments, where he introduced us to how we can come about developing mathematical models. And he also made mention of some assumptions around the models to simplify the model. So, and then thereafter came up Dr. Hafiz, where he took us computing reproduction number. He took us through the process of computing reproduction number. He made us realize the importance of reproduction number and in mathematical models and the interpretation of it. He also took us the techniques of computing reproduction number. Then after that, came up Ms. Ronke that exhibited work on FGS, and that's female genital schistosomiasis, where we are made to see how the importance of mathematical models, mathematical modeling in addressing female genital schistosomiasis. Thereby came up Mr. Olashikbo that introduced us on hands-on on R, some basic computation on R, and also made us to understand that R is an important software in analysis and is an open source language. So then, thank you very much.
All right. Thank you very much, Ms. Ronke, for that wonderful recap of what we did. So we still have a lot of things, much more today. There's still a lot of things to look at, and I bet to tell you that there's a lot to still learn. So starting this morning, so we had a lecture yesterday on mathematical model development. So we are going to have a bit of that in this particular session we'll be entering. So I'll be inviting Mr. Sheo to take us through that. Can we put our hands together for him as he comes forward? Welcome, sir.
Yes, good morning, everyone. We trust we all slept well. And we are getting infected with mathematical modeling, just like Prof said yesterday. So this morning, we'll continue from yesterday. Yesterday, we started looking at how to develop mathematical epidemiological models, and then we started with an SIR model, where we mentioned that in compartmental modeling, we divide the total population according to the infection status of the population, of the people there. So to address one of the questions that one of the participants asked yesterday, that how do we incorporate interventions into models? So we'll be looking at that quickly this morning before we go into our groups. So for the next 10 minutes, we want to see how to incorporate interventions. How do you incorporate interventions and their effects into a model? So let's continue from where we stopped yesterday. Okay, thank you. So yesterday we looked at this malaria model, and then so we can incorporate control interventions into our models in order to determine their effects, and then you can also make predictions about the effectiveness or otherwise of such control interventions. So we're going to be taking as an example the malaria model we looked at yesterday, and we'll see how we can incorporate LLINs. LLINs are long-lasting insecticidal nets into our malaria model. That's the diagram of an LLIN. We are all familiar with the mosquito nets. Are we familiar with the nets? Yes, so this is an LLI. It is treated with insecticides, with chemicals, and so you can, but then the chemicals are not very toxic. So what does LLIN does? What does it do? So in order to incorporate LLIN to the model, we look closely at how LLIN is employed and the effect it has on the spread of malaria. Now the effects of LLINs, they are in two folds. Number one, LLIN can reduce the number of bites from mosquitoes as they physically provide a barrier between the mosquito and the human. So LLIN's effect is in twofold. Firstly, it will act as a barrier between the person sleeping under it and then the mosquito. The mosquito cannot come into contact with the person. So it's acting as a barrier between humans and mosquitoes. That's number one. And then secondly, it can also reduce the population of the mosquitoes by killing them after they land on the treated nets. The chemical on the LLIN is capable of killing the mosquito if they come in contact with it. So we're going to be looking at the effect of these two, how these two phenomena affects our malaria model. So if we let LP be the protection conferred by LLIN, then LP, okay, thank you. Oops. LP, this guy, is a function of two terms. the efficacy of LLIN and the coverage of LLIN. So this guy, the protection that is conferred by LLIN is dependent on those two terms. And where does the effect of LLIN, where is it being incorporated in the model? The effect of LLINs are incorporated in the two forces of infection with a reduction parameter given as 1 minus LP. We're going to be seeing that later on. That's where the first fold, remember we said the effect of LLIN is in twofold. Number one, it acts as a barrier such that the mosquito cannot come in contact with the human staying under it. And it has acted or prevented mosquito bites. Is that clear? So that's the first effect. The LLIN acts as a barrier and it prevents mosquito bites. Then secondly, we say that it also acts as a killing agent. It can also kill the mosquito. And that's what in the second, this second part there. There's also a separate death rate, mi of M1, in each of the mosquito populations. Remember in our model yesterday, so for our model yesterday, media, can you help us with the slide? Okay. So here we have natural death rates for each of the mosquito population. Natural death rates, mu m for each of the. So now we add the effect of the killing effect of LLIN, and that gives us this additional death rate. So thus the mosquito death rate is given by this, where this is the natural death rate that we looked at yesterday, and this guy is the death rate caused by what? Caused by the LLIN. So we now have this particular function there. And now we can now have these two effects incorporated into our malaria model. And so this is our malaria model, now incorporated with LLIN. So we have this, the original force of infection is B, which is the biting rate, beta MH, which is the transmission rate that we mentioned yesterday from mosquito to human, and then this is infectious mosquito over NH. Now we incorporated the effect of LLIN here, which is given by 1 minus LP. Now if the efficacy, or if LP equals to 1, what does that mean? If the value of LP, this protection that is being conferred by LLIN, if it equals to 1, what happens? If it equals to 1, it means that the LLIN, the protective effectiveness of LLIN is 100%. Is it not? It means it is 100%. That means it confers 100% protection. And so if it is equals to 1, I have 1 minus 1 here. What happens to the force of infection? If I have 1 minus 1 here, this is 0. So 0 times whatever we have here, what is it? 0. So that means there is no transmission. If my LLIN is 100% effective, there will not be any transmission. The mosquito cannot come in. So what if it is 0.5? If the value of this guy is 0.5, what happens? So I'll still have a level of, that means it could be that the efficacy of the LLIN is already waning, or probably it could be that there are holes in the LLIN such that the mosquitoes can still get access into the LLIN, and it's making your LLIN not 100% effective. Now, that factor is in this force of infection. It is also here too. Remember yesterday we mentioned that mosquitoes do not just get the parasite from, mosquitoes do not just pass the parasite to humans. Humans also pass it to mosquitoes. And I remember there was a question yesterday, which one comes first? Is it the mosquito that first gave humans the parasite, or is it humans that first? So I tried to do a little search last night, and I think it's suggesting that humans are the culprits. we are the ones that gave mosquitoes. Some of the little search I did yesterday suggest that it was actually from human first. That plasmodium, the plasmodium parasite is actually from human first, and then we transfer it to mosquitoes. No, I did a little study yesterday, Prof, and historically they were saying some studies show that it was actually from gorillas and apes, and so it seems it got transferred to humans. But we can still look around that. But study the little research I did yesterday. I'm not making an affirmative statement, but the little research is tending towards human being as humans as the original hosts. But we can it's still debatable though. So we mentioned yesterday that mosquitoes can also get the parasites, and so if a susceptible mosquito, say I am infectious with malaria, and then I'm sleeping under the net, and then a susceptible mosquito is trying to come in, what happens? The net is serving as a what? Barrier. So the susceptible mosquito cannot get or access to me and cannot pick the parasite from me. Do we get that? So that is what is happening here. So that's why we said the protective effectiveness of LLIN occurs in two parts. Here in the force of infection here, it's also coming up here in the force of infection. So it can reduce the effect or the rate at which mosquitoes also get the disease. And also we also mentioned that the second fold effect of LLIN is that it causes it can also lead to death. It has a killing effect. The chemicals in LLIN can also kill the mosquito, and that is reflected in the new, look at now, we now have a modified death rate for each of them, each of the compartments for the mosquitoes. Is that clear? Do we get that? So this is just a simple way of incorporating control interventions into our models. Firstly, you need to understand any control intervention you want to employ, you want to deploy or you want to incorporate into your model. You first need to understand how it works. What is the effect of that control intervention? How is it being employed? What are the characteristics and the features of that control intervention? So that leads us to group work now. So like we said yesterday, we'll be dividing ourselves into compartments, but in this time around, we'll not be dividing according to infection status. We'll be, how do we go about it? Okay, maybe we'll group according to numbers. So maybe we'll pick numbers. Let's pick numbers from, sir, you pick number 1, 2 to 4. 1, 2, 3, 4. So, sir, number 1, 2, 3, 4. 1, 2, 3. Please, let's take note of our number. Should we start again? Okay. 1, 2, 4, 1. All right. Thank you, sir. So we'll be, I think to be on the safe side, we may have to close our laptops so that it won't fall off. And then we can go to our groups. The first group, we are to develop a COVID-19 model that incorporates 2 pharmaceutical interventions. What are the pharmaceutical interventions? Can we mention them? We mentioned them yesterday. Let's remind ourselves. Vaccination, what else? Treatment, what else? Huh? So at least we've gotten 2. What about the NPIs, the non-pharmaceutical interventions for COVID-19? Face mask, social distance, hand washing, quarantine, what else? Isolation. Those are the NPIs. Social distancing. Those are the NPI interventions for COVID-19. Then we have to develop group 3. We develop a model, a malaria model that incorporates IRS. What is IRS? Indoor residual spray. So you need to understand how it works, how it is being deployed, and then vaccination too. We now have vaccination. Vaccination is being employed in Nigeria now. Last year, November, 2 states were targeted, Kebbi and Bayelsa states, and then children under 5 were given the vaccination in those 2 states. Were given vaccination. So Dr. Hafiz will be leading that group, and then the 4th group they are to develop a malaria model that accounts for seasonality while incorporating ACT. What is ACT? ACT is what? Artemisinin. All right, so those in that group will be Mr. Aaron and Ms. Runke will lead that group, and then you'll be developing. So there's a bonus work that you can take home, and then you can look at your free time. Maybe you can then send the model to the WhatsApp group. You can develop an MPOS model that incorporates isolation as a bonus work for every one of us who can try our hands on that. And so let's go to our groups. Group 1, Dr. Daniel. Quickly, we have 10 minutes to formulate this model, and after that, we'll have few minutes for each group to come and present their model, if we have time. Dr. Daniel, Group 1. Who are those in Group 1? Please, Group 1 can go to that side. Group 1, please, let's be on our feet. Quickly, we have limited time for this group work. Limited time. We have Group 1. Okay, Group 1 by being led by Dr. Daniel. Then Group 2, Mrs. Oniyelu. Where is this Mrs. Oniyelu? Please meet her quickly, and let's formulate a model. Quickly, Dr. Hafiz, Group 3. Is Dr. Hafiz here? Okay, Group 4, Mr. Aaron and Ms. Ronke. Group 3. Okay. Group 4, please meet Mr. Aaron. Okay. All right. Group 3. Where are Group 3 members? Group 3 members, we can use Mr. Daniel. You can. Group 3, Dr. Hafiz. Group 3. Group 3 members, where are you? Okay, they are there, sir. Group 2. Group 2, yes. Group 2 is Mrs. Oniyelu. Where is Mrs. Oniyelu? And Mr. Sampson. Mr. Sampson. Mr. Sampson, your group. Group 1 members, please go there. See your name there, Mrs. Oniyelu and Mr. Sampson. We are going to join them. It's after the model development. We have 7 minutes more. 7 minutes more. We have 5 minutes more. Sorry. Fine, fine, fine. 5 minutes more. So maybe an isolation. We have 2 minutes more. 2 minutes more. Two minutes more. I was not able to do it. It's just one mic. 'Time up. Our time is up for our group work. Our time is up. So let's return to our seats. You can always go back to the group work during tea break or lunch break. Group leaders, our time is up. Thank you. Thank you for your cooperation. So we can always during lunch break or tea break or even after closing, we can always interact.
All right, please, let's go back to our seats. Thank you. Let's go back to our seats. Yeah. Thank you, thank you, thank you. The discussion can continue during our tea break or our lunch. All right, let's go back to our seats. Let's have another beautiful session. Group leaders, let's release our people so that they can go back to their seats. We can continue the discussion during our breaks. Thank you, thank you. Let's go back to our seats. Thank you. Group 1, let's go back to our seats. Thank you. All right, let's settle down, please. Let's settle down, please. Let's go back to our seats. Thank you, thank you, thank you, thank you. Please, we can continue the discussion. The discussion is not over yet. We can continue during our break. So let's go back to our seats. Thank you. Let's have our seats, please. Thank you. Thank you very much. All right, so we are going to go to the next session now. So the next session is on general. Can we have one house, please? So we are going to go for another session now. So on general data source for infectious disease modeling. So taking us through that is one of our PhD scholars at Icammda. So I'm going to be introducing Mr. Aaron as he takes us for this section. Can we put our hands together for him as he comes up? Let's put our hands together as he comes up. All right, thank you.
All right, so this morning I will be taking us on a course which is general data source for infectious disease modeling. So just as we've learned yesterday, if we at all want to do any mathematical modeling at all that will speak to policies, that will speak to decision making, that will transcend not just the academic environment but to policy making, we have to do such modeling with data. Data must be put in place for us to do any meaningful modeling work at all. And as such, we want to look at some of the sources where we can get this data from, and also the implication of each of these kind of data and where they are being gotten. Some of this data are open source data which are easily accessible to everyone, while some of other data you have to get some permission before you can be able to get hold of those data. But be it as it may, whichever one it is, you must need data to be able to speak or to be able to develop any good model that will inform policies, whether national policies or subnational policies in Nigeria. So there are some of the acronyms which I'll be, abbreviations which I'll be using in this presentation, and some of them are listed here, such as the Health Management Information System, the District Health Information System, which records routine data, therapeutic efficacy studies data, which has to do with some sentinels across the country. We also have routine health information system data as well. We have data that has to do with surveillance, monitoring, and evaluations. We also have to do data that has to do with health, demographic, and surveillance system. So all of this has to do with data right from the subnational level down to from the communities to the state level to up to the national level. So each of these strata have data that are specific to them, and for we to speak to any of these to any policies from this in this subnational level, we have to get the data that speak to each of these, and then we are able to model and get informed decision and make informed decision based on the data that are available to us. So particularly speaking, to monitor activities and to also ensure program meets their objective, we need data, and those data are raw information, raw facts that particularly have to be analyzed, and when they are analyzed, that is when information are being gotten. A data that has not been analyzed as raw facts are just facts that are there. You may not be able to see the internal intricacies or information in those data, but when you analyze those data, you look at those data inside it and analyze them with various analysis software, then you'll be able to get the intricacies and the pattern in those data, and you're able to make informed decisions. So particularly we have raw facts, which are the data, and then the information after processing such data are what we get, and then we have to also from those information get a message knowledge, and this message knowledge is what can inform policies, what can inform programs, what can inform whatever we are doing in the country. And to get this flow, we have to know that just as we learned yesterday that the real world is full of so many stochasticity, is full of so many noise. So just as Prof said yesterday, we cannot really replicate a real world problem twice. If we say we want to replicate perhaps what happened in this hall yesterday, we may not exactly replicate it, all right? So the real world problem is full of so many intricacies, and for us to get even a picture of what is happening in the real world, we have first of all have to collect data. And then when we collect data, then we have to process data, process the real world problem. And then that processing of the real world problem is what gives us information. And those information is what we use to now inform policies in the health space, is what we use to inform policies in any of the space, whatever we are modeling, whether in the health space or in the economic space or in the battlefield, talk about the war models and the rest of that. Those information we collect is what we use to inform those decisions we are making. So just like Prof will always say that data now is the real, where we have the real value, not really in the oil now. So majorly in our collection of data, we must know that data is now real wealth. And if you are able to analyze, you are able to get this data, you are able to analyze them, and you are able to give decisions based on those data, you will see that the world will come to you, because people want to know, okay, what actually will happen tomorrow? What actually will happen the next year? What actually will happen in the years to come? They want to see predictions. They want to see informations which will guide policies. They want to see trends, patterns that will help them to give information, whether it is in the weather space or in the health sector as well. So data can be classified into different kinds based on the needs. One of them is the primary data and secondary data. In the primary data, the investigator have to, on its own, go to the field and get those data. While the secondary data, the investigator have to depend on some kind of repository, that is secondary repository, which is particularly what the mathematical modelers do. So they depend on repositories of secondary data sources. Talk about for example, we model malaria in our center. We also model STH, and as well as so many of the neglected tropical diseases. And each of those diseases have their repositories where you can go and get data. Some of them are open source, like the DHS data, the MIS data, and the rest of that. While some of them you have to get permissions to actually log into the space where these data are there, so that you can get those data and then make your models. So we also have data that can also be classified based on soft data and as well as hard data. The hard data has to do with numericals, values, information which you can code into maybe numbers or based on some categories which can actually give information. While the soft data has to do with opinions of individuals, which may not really be easy to put some labels to, or may not be easily put some categories to. So one distinction between the hard data and the soft data is that the hard data, even if you change those individuals collecting the data, at the end of the day, whatever they are collecting will still be most likely to be similar. However, but in the case of the soft data, if you should change individuals or the collectors, then you may likely find that what you have previously and to what we have at the moment when you change individuals may look different. So that is a bit of a distinction between the hard data and then the soft data. The soft data actually has to do just opinions of individuals. Majorly they build in subjectivity. Majorly they build in many complexities to it, and it has to do with the personalities, because personality actually will affect the collection of soft data. And then for the data sources, particularly we have the HMIS, that is the Health Management Information System, which record the routine data for DHIS2. And here we have so many health indicators. Particularly what we have also in these health indicators is the malaria data. So once you log into this data source, you're able to get information that has to do from the subnational level, that's talking about the the communities, the local government, then to the state level, and then to the national level. You get this data aggregated in those order. And then we have sentinel surveillance, which has to do with data that are collected some kind of periodically across some sentinels. So there are some data that are not national, that are not nation-based. They are not collected all over the nation. So they kind of had to create some sentinels around the country, or some sentinels in the state or in the local government for such data. Example of such data are some of them we have from the entomological surveillance data. We also have the therapeutic efficacy data, which I think now we have about 14 sentinels in the country that actually collect this therapeutic efficacy study on ACT particularly. So for entomological data, we have some states like Kebbi State, and some other, I think about 6 of those states that also collect entomological data. Then we also have for routine data too, for administrative systems, we also have vital registration system, which of course in various health facilities, in various both the community health facilities which we have in the communities, in the local government, we see that each day they account for cases, whether malaria cases or some other disease outcome cases. Each day they are being recorded. At the end of the day, they are put together to the local government level and then to the state level, well, at the national level, until they are able to use this data to inform decisions, to inform policies. And then the national level also use this data too to apply for grants from donors. So particularly again for the routine data, we have program reporting system, we have surveys, which has to do with facility and also household surveys. So we have also census that comes up, I think at intervals for Nigeria. I think every 10 years we need to conduct census. The last one that was conducted was 2006. We should have one again around 2016 and even next year 2026. But that is what ought to be done, but perhaps it's not being done all of the time. So we have also data that are collected routinely, such as the KII, which is the key informant interview, the focus group interview as well. So we have direct observations, research studies, and as well as rapid assessment. So all of these can be collected routinely as depending on whatever research question that we have in grant, and also the model that we seek to develop. So particularly for any surveillance and monitoring and evaluation system, it helps to collect, these are processes that help to organize one data. First of all, you have to gather the data and then use the data to create information. And then those information should be able to what? To direct policies, should be able to inform decisions, should be able to give guidelines where particular health interventions should be deployed, whether it is LLIN for the case of malaria, where should malaria be deployed based on the surveillance data, ACT, where do we need to top up our game in terms of deployment of ACTs, in terms of seasonal malaria chemo prevention, SMCs, where we need to top up our game based on seasonal variation in terms of malaria transmission. So surveillance and monitoring and evaluation will help guide those kind of decisions. And for we to get those kind of data, you have to depend on the ROHIS, that is routine health information system, to guide that kind of data collection, and then the health facility survey that based on the primary health facilities we have in the country, from the local government up to the national. And then we have to also rely on some focus group discussions, the KII, the key informant interview as well, for implementers of this program. We also can get data from verbal autopsy, that is talking about if we want to get, okay, what is actually the cause of death, and you have to deploy informants to actually make these interviews to come up with verbal autopsy that is that might likely be the cause of death. Then we also have household surveys, which is particularly what the DHS uses, also and MIS uses in terms of collection of their data. Then we have data that has to also do with geographic information system, which has to do with some mapping here and there, which will actually give information of what kind of health outcomes that we can deploy in a particular location, and what health outcome we may not want to deploy in some certain health settings. So we also have, of course, the Sentinel surveillance, which I've talked before now. We also have the operational research. For us to come up with any operational research, we must use credible data and credible data source. And in fact, it is not very, and it's not even good for you to report anything mathematically without actually providing the source of the data where you are getting that. So the data is, your model is as good as where you are getting your data from. So data is very important in developing any operational model at all. So we also have the routine monitoring and the community levels, and then the health demographic surveillance and systems data, which has to do with majorly DHS survey and MIS survey. Then for routine data at all, some of the functions of the routine health information system data is particularly one, that the collection must be done, and then individuals collecting data must be able to compile this data, and then must be able to transmit. If data are being collected without necessarily transmitting this data, then the whole bulk work of the exercise is being defeated. So data must be collected and then be transmitted. And again, data being transmitted must be analyzed for any information to be gotten from that kind of data. Then when it is analyzed, such analysis will be used for what? For decision making, and also for, of course, for prospective, and also for some retrospective information as well, for making predictions and making patterns as the case may be. And the purpose for making data collection is particularly for decision making. For decision making, to provide stakeholders and users with health system useful information that they need, and then to support research for health. So if we're able to collect data at various levels, it's particularly help the research that we are doing. It's particularly help not just our research, but also research that cuts across the country, and also cuts across not just our country, but other countries, because it promotes international exchange of health data. So this much like a schematic diagram of how the flow of data is. So from the district health information system, we can see that it is not just collection of data is not just for the health practitioners alone. We also have community involvement, like the community based health information management system. So community feedback to the PHCs, which is the primary health facilities that is located in the various locations, and then the PHCs have to feed back to the local government authorities, and then the local government to the state, and then to the national. And this must stem from the community. And we have community vanguard that has to do with health collection data. We have the CDDs, which has to do with the community drug distributors. We have the CDI for the community drug intervention. And we have various stakeholders within the community level. They may not necessarily be health practitioners, but there are those that are being trained by health practitioners to collect some of this data within the community, and they are being given the trust from the community leaders to actually collect this data and then pull them together to various primary health facilities, and then to local government and up to the national. And this we see in the second schematic diagram, that it's not just mere collection, but it actually drives information. And part of this information is when you look at what happens at the national level, that it helps in terms of system, and also help in what dissemination of information. And not just dissemination of information, it also helps the national to actually apply for some grants. I think there is another, when we go on, we see that it also helps the national to apply for grants which they need in terms of making policies, in terms of creating interventions, in terms of deployment of interventions. Some of these are very important, and it does not start from that national level. It starts from the bottom to top approach. And then we have various other areas where we can actually generate data, and part of those areas is registers from the clinics, from the clinicians. Talking about data from the outpatient department, that's OPD, talking about data from antenatal care units. Of course, we have various data from pregnant women. And if it's in terms of malaria, we have when IPTP, that's intermittent preventive treatment for pregnant women, and this is being given as SP, that's sulfadosine parametamine, and these data are being recorded under the routine health information system. We also have the immunization data as well. Of course, we just heard from the last presenter that now we have vaccination for malaria, which is being deployed in Kebbi State as well as in Bayelsa State. So all of these are what is necessary in terms of collection of data, even from the health facilities as well. And also the health facilities in terms of reporting. We see that a doctor or a clinician, when collecting data from individuals, so from individuals, we always ask vital information. We always ask, take some key information, and these records are being taken care of in the routine health information system. And particularly, those data are being aggregated in terms of based on maybe weekly, monthly, and sometimes quarterly. So for us to have an efficient routine health information system, particularly we must pay attention to the coverage of such routine health information system in terms of the sector, in terms of the region, and also the district. Then we must also look at, okay, what is the accuracy in terms of the routine health information system? So it must be accurate. Many a times we have our, when we look at the data from the routine health system, we have some loopholes there that are not really suggestive of data that is being accurate. So for us to actually deploy, for us to actually take care of any data, then we must have to look at, one, the accuracy of the data, then in terms of the coverage, and also in terms of the completeness of the data. Sometimes you look at the data, you have missing or non-available information in those data. So these are of the areas which, of course, the health practitioners and as well as those that are the programmers have to also look into in terms of giving out those completeness in terms of data sources. So we also look at the frequency of collection in terms of the routine health. It has to be more, it has to be an everyday report which can be collected in terms of monthly or quarterly. Then we have other mechanisms of analysis of this data, and then mechanism of information dissemination. So we can adopt any of the mechanism of information dissemination. It can be within the community level in which information are being distributed in the community. It can be from the local government, that the local government information is being distributed. It can also come to the national level, that information has to be distributed at the national level. And then the national level will also take it from the top and also down to the bottom approach. So we have various drivers in terms of the routine health information system. And part of those drivers is we must have standardized indicators. So for we to have routine data collection, there must be standardized indicators. Some of these standardized indicators have to do with what parameters do we want to measure. And it's very important because for the health practitioner, they may not really understand some of the questions that the mathematical model want to answer. So for us to actually have a link to some of this data, we have to tell them, okay, these and these questions are what mathematicians want to answer. And and from that information, they will be able to now collect such data, which will drive policies and information. So there must be a standardized indicator, whether it is in terms of the cases, or in terms of the deployment of intervention, or in terms of whatever regulation that have been deployed over time. So the data collection platform, so there must be a database that we will have this repository being deposited as they are being collected. So some of these are requirements. There must be an appropriate information technology. Those collecting this information must be well equipped in terms of the technical know-how and as well as the skills to be able to collect this data. So we also look at the organization in terms of the structure, like I've said, from the bottom-top approach and also from the top and bottom approach. And then we have the behavior of the health collectors. They must be well motivated. And of course, their attitude must be right to be able to collect this data. And so those form some of the strengths in terms of routine health data collections. And also, of course, the routine health data collection also have her own limitations. And part of those limitations is that, of course, this data cannot be generalized. Yes, it can be generalized, but data are limited to only the health facilities. Okay, so it's just the health facilities that are able to get this data. It is not a data that you can use to say, okay, this is the prevalence of such disease. Because take example, instance for malaria. For malaria, we have so many asymptomatic individuals, as well we have individuals that didn't even visit the health facility for treatment. They will just go to some drugstore, take malaria drugs, and they are okay. So a routine health information system may not be able to generalize in terms of the prevalence of that particular disease. So this routine health data is also poorly funded. Of course, the health practitioner will always tell you to put more funds to the health intervention. Of course, they are poorly funded. But some of these the strength of this is that they strengthen subnational level surveillance and, of course, response for priority disease, and also share resource among disease control programs. And then we also see that they are timely. Of course, they are being recorded every day, and which is aggregated in terms of the month, or also in terms of quarterly aggregation. So this actually explains the bottom-top approach, and as well as the top-bottom approach in terms of generating this data from the communities and then transcending them to the State Ministry of Health, and then to the Federal Ministry of Health, and up to where the Federal Ministry of Health can actually send this information to donor agencies, as well as donor agencies which will help in terms of providing some resources for deployment of some of these interventions. So we also have on that kind of data which has to do with integrated data resource repository as well. And some of this has to do with surveillance, and then they generate data in terms of surveillance. And then this surveillance data is able to give information. It's not done across all board. It's not done generally in all of the country or in all of the health facilities. Just select some strategic health facilities based on some key factors, and then information generated here can then be generalized for all of the countries. And so that is one of the strengths in terms of IDSR data source. So particularly this data source, it can be used to signal trend in health outcomes. It can be used to identify outbreaks. It can be prompt identification of outbreak is in terms of the integrated disease surveillance system. So also it can also be used to monitor the burden of a disease in a community. And then for us to, for consideration of selecting the sites for such surveillance data, we have to look at the distribution of the disease. So we have to look at the prevalence of the disease in any certain location. Is the disease being prevalent in that place? Take, for instance, the Lassa fever case we are talking about. So we see that we have more of the disease here in Ondo State and as well as in Edo State. So they have to develop some kind of laboratories in these two areas to be able to monitor, routine monitoring of the disease. And that is what this kind of surveillance system is programmed for. Then we also have, of course, the sentinel surveillance, which has to do with selection of strategic location. Also could be based on, in terms of the prevalence of the disease, could also be based on some facilities available in those locations, like, for example, the laboratories and also the technical know-how, and then they are being set out, sentinels are being set out. For example, we have the therapeutic efficacy study for ACTs. We have 14 sentinels in the country, and they are being segregated to also meet the ecological zones of Nigeria. So they are being set out they are being mapped out in each of the ecological zones, so that data aggregated from each of such ecological zones can be put together and then can inform decisions within the country. And part of the limitation of sentinels is that, one, of course, it is costly to set up. It's very expensive to set up because it requires a lot to be put into place. Then it requires frequent supervision. And of course, it is not a representative of all of the health facilities because of the expensiveness of the nature of whatever of the health outcome we want to interpret or want to bring to bear in the nation. It's very cumbersome to set up, and as such, it is not being duplicated in all of the health facilities we have in the country. And it's not always sustainable. Of course, it's very expensive to maintain surveillance, and so it is not sustainable and easily experience some stock out once there is limitation in terms of funding from the donor agencies, because this surveillance has to depend so much on donor agencies to be able to fund any sentinel activity that's been going on in the country. So, and this table also give a kind of distinction between these different data sources. For example, for the routine health information system, this has to be carried out across all health facilities, while for the other, to the IDS as well as the surveillance, has to do just from few health facilities in terms of, based on those criteria which we've highlighted earlier in terms of where do we have the disease prevalence, where do we have some peculiar health facility to be able to respond quickly to some of these health outcomes. And so we also have the frequency of reporting. In terms of the frequency of the reporting for the routine, we have this can be aggregated to monthly reportage and as well as quarterly. Why? For the integrated disease, because this is actually required for quick response. So we have weekly reportage for this kind of data, where for the sentinels, also it requires quick response. It has to do with daily, weekly, and as well as monthly reportage of whatever health outcome that's been investigated for the surveillance study. Then for the collection, for the case definition, for the routine health, we have to dictate the case. With diagnostic too, we have to dictate the case before you can say, okay, this is a case. Why for the integrated disease surveillance system, even both the suspected cases and as well as the confirmed cases are treated as cases at the initial stage. Because, for example, when COVID-19 broke out, anybody that is being, okay, we talk about the index case now, anybody that has been exposed or come in contact with the indexed case, what happens? What happens? They are being quarantined. They are being treated as a case. They are being, okay, come first until we check you for some certain number of days before we can satisfy, okay, this person is not having the infection before. So for the integrated disease surveillance system, we have to treat everyone, both the suspected and as well as the case as cases at the initial start, so that we are able to monitor the outbreak and also prevent outbreak in the population. So particularly for surveys as well, surveys too are great channels where data can also be sourced, and particularly important for us in the mathematical model for malaria has to do with DHS survey, and as well as the MIS survey, and also the mix as well. So these are great data source for mathematical modeling of malaria, because they give the DHS is being conducted every 5 years, and MIS in between those 5 years. It may not be a continuous something every other year. It may not be a continuous collection of the data every other year, but the data that has been collected at these intervals is able to respond to, okay, what could be the likelihood of what is actually happening in the country in terms of malaria prevalence, because it is being done virtually all over the country based on some statistical tools that are being used to select for sample size all over the country. So the strength of the survey has to do with that it measures several outcomes and predictors. Of course, it is cheaper, and then it is a longitudinal study. Then it is nationally representative, and that we can use it for, of course, to talk about a national trend, because it is based on some sample selection across all of the areas and strata of the nation. So we can use it as a representation of what is happening in the country. And then it is used for a multi-country comparison. We can compare it with what is happening, because it's being conducted like the DHS. It's not just Nigeria, it's being conducted virtually all over Africa. And so you can see, you can compare what is happening within West Africa. You can compare it to what is happening between the East Africa. You can compare with what is happening based on whatever disease outcome you may want to use to compare. And it can be used for multi-year comparison as well. In the same, of course, in the same population. You can use it for different years. What has happened in 2010, what has happened in 2019, what has happened in 2021. I think 2021 is the most recent DHS or MIS data we have. So you can use it for multi-year comparison of how the trend of malaria is going, how is it reducing, or how is it increasing, or how, what is really the trend in terms of malaria cases or prevalence in the country. Yeah, but it also, surveys also have its own limitation. Part of it is it's very complex to design. Talk about the questionnaire that has to come up in such a study. It's very complex to design, and also has a recall bias. For example, if you have to interview individuals, maybe take a household survey, and you go to a household, you have to interview individuals based on their health outcome. The question would be, would they be able to recall whatever would be their exposure over time? So it has some recall bias, of course, time consuming, and the rest of some of these limitations that we have in the survey. For example, the DHS and as well as the MIS data. So the purpose for this is that it links population provider and access providers' behavior and also performance. It's also give understanding in terms of relationship between providers of some of this intervention. And for us to carry out a good survey, then we must have to have the right tools. And some of the right tools is in terms of direct observation. We have to also have the tools in terms of record. We also have, so we have to also look at the record review, and as well as also the interviews. So the strength of survey, of course, it assesses quality of healthcare and the rest of some of those importance. Of course, for us to carry out any study in terms of survey, it must be operationalized. It must be a survey that will be able to guide policies. A survey that will not guide policies is just a waste of time. So if a survey can guide policies like DHS or MIS or the mix, then it is worthwhile in terms of carrying out. So in terms of summary for this, so there are many issues with the data available to measure impact at national level. And much of the data used to measure impact comes from large-scale population, and that has to do with survey. So there are many intricacies here, and there's also many loopholes here, but whichever the loopholes or the case may be, it is always a representation of what is actually happening in the population. We will not say we want to throw it out because it's not encompassing all of the health facilities in the country, but since it's able to provide some guidelines, it's able to provide some information, it's able to provide some leeway for us to see what is actually happening in the community, in the local government, in the state, and as well in the country. So it is an exercise that is worthwhile for us to engage in. And so these are some of the data sources which we have in terms of if we want to actually go into malaria modeling or any modeling of infectious diseases, we must look out for where are those data being reposited, and then if there are data that are open source for us, then we have to mine those data. And if there are those that are not open source, then we have to seek for permission to get hold of those data. Because if we at all want to make any operationalized decision model at all, we must fall back to data. So data is the key to make any operational research. Thank you.
Can we put our hands against once more for Mr. Aaron for that presentation? All right. So one of the things I picked from that session is the fact that to inform policy, you need data, which is very, very important. And in order to do meaningful modeling, you need data. So I don't know if I just want to entertain one question in regards to his presentation, then we move to the next. One question? Anybody? The audience? Okay, Miss we don't have any questions. All right, thank you very much. Okay, there is one. All right, let me. One. Okay.
Thank you. Good morning, sir. I'm of opinion that since you've been interacting with some of these websites, and I think you can give us some of the website that you think are important that we can easily go and get some of this data.
So particularly I will give reference to the DHS. Just go to your search, type DHS, you will see the DHS is in. Then also for the MIS the same, and also for the routine data for the DHS IS2. So you can also get that. That also give routine information, routine data for so many health variables, DHIS2. So that you can see so many health variables and so many indicators for so many diseases. Also, you can also, of course, check the NCDC website, which will also give you so many data source for some of these infectious diseases that we have.
Thank you very much, Mr. Aaron. Can we put our hands together as it goes back? So, all right. So, going in the next session now, we have more like an exhibition on something on machine learning. So, which are one of the tools we use in infectious disease. So, given that presentation is a PhD scholar at Icammda, also that's the person of Mrs. Oniyelu. Can we put our hands together for her as she comes up?
Good morning, everyone. Good morning, my professor. Thank you for the privilege to have this presentation. So I'll be looking at malaria in pregnancy. Malaria in pregnancy is a known global health challenge of which 125 million pregnant women worldwide are said to be at risk of this, which can cause adverse birth outcomes and also maternal deaths. It can also cause anemia in pregnancy. It can also lead to stillbirth if not treated. So, Plasmodium falciparum is a major parasite that causes this infection when an infected female Anopheles mosquito bites a pregnant woman. So, like I said before, it can cause maternal anemia. It can also cause low birth weight. And for women having their first pregnancy, there are higher or lower immunity to malaria in pregnancy more than compared to those who have had several children. So when this parasite or when the infection gets to a pregnant woman, it goes into the maternal placental vascular space,
and there will be sequestration, which can reduce the level of oxygen carrying capacity to the fetus, and this can have dangerous effects on the developing fetus and also on the mother. So 40% of pregnant women worldwide face the possibilities of being exposed, and 25% placental infection show evidence of this, of placental infection at the time of delivery. So there are various studies that could be done. You can either look at the age as a risk factor when looking at the number of pregnancies a woman has had, or we can also look at the location of the pregnant woman. A woman who is in a endemic setting like the sub-Saharan or Nigeria must be treated of malaria in pregnancy to avoid adverse effects. And then a person who is in a low endemic environment, there are lower chances of being exposed, but immediately they are exposed, they also face high risks. Who recommended that there must be some line of interventions. One of them is the presumptive malaria treatment, that immediately a woman is pregnant, she has to be tested to check if she has malaria. So if there are no malarias, then you can go ahead to get your IPTP at antenatal care visits. And if she has malaria, then she has to be treated. But of course, continue with the routine IPTP treatments. Also, we have the long-lasting insecticidal nets, which are used to promote protection of bites to reduce the risk of malaria transmission and infection during this vulnerable period of pregnancy. So IPTP SP, which is administered to pregnant women, reduces the parasite burden in the body of the pregnant woman, and also it is cost-effective, making it a practical choice for resource-constrained settings like Nigeria or endemic settings. It's an essential component used in malaria control program for pregnant women. Also, studies have shown that IPTP SP improves birth outcomes by the increase in birth weight and reduce the risk of prematurity, leading to healthier infants. Long-lasting insecticidal nets, they cause a physical barrier that provides physical protection against the mosquito bites, reducing risks. And then the insecticidal effect makes the mosquito to repel or kills the mosquito, which also reduces transmission. There's also widespread use of LIN, not only protects the individual pregnant woman, but also contributes to the community's control of malaria and transmission within the population. So machine learning can be used in various ways. One of the ways is that you can study the trends of malaria over time among pregnant women. National effort has been deployed over the years to target reduction in MIP incidence. So we want to look at some time series analysis of trends of malaria in pregnancy from historical data, and then forecasts to understand how the incidence has been despite all the interventions that have been deployed so far. So machine learning is very important in disease surveillance, and they have really improved or transformed disease surveillance. They offer unprecedented accuracy and speed. So we're going to looking at how this can help in the preparedness and monitoring of malaria in pregnancy. Okay, like I said, it helps accuracy, preparedness, and provides 24/7 monitoring in many countries. Okay, so to study, we carried out a trend analysis on regional variability in malaria in pregnancy within Nigeria, and the 6 zones we have the north east, the north west, we have the north central, the south, the southeast, and the southwest. So from that study, we saw in the trend that south experienced its highest peak in 2017, which may be a reflection of what happens in that environment, while southeast experienced its own lowest trough in the same year. So we can see that what's happening in a region is not necessarily the same thing happening in another region. In the same year, the south had its highest peak, while the southeast had a trough. Then the north central they recorded the lowest change in malaria in pregnancy to be 2.58, suggesting a stable but persistent malaria burden in that region. Here also we try to compare to see the level of endemicity in various regions, and we discovered that the south, the southeast, and the southwest, they had lower than the troughs observed. They were lower than the troughs observed in the northeast and the northwest. That is, these regions, even with their peaks, were lower than troughs found in the north. That means the highest case you can find in the south is not compared to even the lowest case in the northeast and northwest. This suggests that malaria burden is generally higher in the northern regions. Also, from the picture we have there, we can see that the higher frequencies, especially in the northwest, north central, and northeast, were shown. This shows that there is need for more coordinated strategies to actually tackle malaria in pregnancy in those areas. But whereas the south-south region just had some few patches of concentration of malaria in the region. So like I said before, it demonstrates that the highest incidence of malaria was found in the northwest, and a high correlation with the number of cases, thus needs urgent intervention. The north central was found to be one of the leading, the malaria was found to be one of the leading causes of maternal mortality in the north central. So continued monitoring and surveillance is required. And the northeast the region is burdened by the of insurgents. This has led to the disruption of health services and increase in malaria cases. Insurgents like kidnapping and communities leaving their settlements, internally displaced persons, which has increased the risks of malaria cases. So here we have some results. We carried out ARIMA analysis, and after the testing the results of the analysis, we discovered that there's a need for a unique model for each region. It's not the same model that works for every region or every state. So developed for each region, reflecting the distinct dynamics of malaria transmission in each region. And then persistent autocorrelation was observed in 4 of the regions, which shows that seasonality has a strong effect in the transmission of malaria. So these are some of our results. So there's need to prioritize interventions for the northeast and the northwest, intercenter treated nets, IPTP, and then early dosing and treatment. Like in some of the northern states, pregnant women don't really come out for antenatal on time, until when they're advanced in the pregnancy. So there's need for early diagnosis so that if there's malaria in that pregnancy, it can be treated on time before it affects the fetus. Also, we discovered that records in malaria in pregnancy seem to have a lot of missing data. You know, there's a routine collection of data monthly collected from various primary centers, primary health centers to the local government, then collected, then summed up at a state level. However, a lot of missing data, and then for some years now, records have been missing. So there's a need to encourage and maintain accurate, up-to-date records. Also, regular analysis of data collected is needed to identify hotspots, and there's data utilization helps in proper planning and resource allocation. This will help in achieving the goal of the National Malaria Elimination Program of the country. And there's a need to also train the primary health facilities the importance of this data, so that missing data will be avoided. This will ultimately help in achieving elimination. So, some of the takeaways from this case study shows that there's regional variation, consistency of record keeping is needed, and then targeted intervention. So, future directions, there could be need for understanding why the prevalence of malaria in the north is higher, but maybe there is drug resistance or not. Thank you for listening.
Yeah, thank you so much, Mrs. Onielu, for exhibiting that work on time series analysis using machine learning. Okay, approach. I know that yesterday, while we started this program, people introduced themselves. Some said they are doing something on machine learning. So I'm sure that you'll be happy seeing that it's not only susceptible, exposed, infected that that has been projected. At least something that you can appreciate has been presented. And so for me, I think that's a good one, so that we have a mix of everything. Now she has presented a work that she has been looking at. And I know also some mathematicians are seated and wondering also that we also do this in modeling. Now, let's talk within the next 2-3 minutes. Let's engage the presenter who has presented to us questions. I was just expecting that. My HOD, I was expecting my HOD to do that. And immediately I saw his hand up. All right. So, Mama, the HOD is here to ask questions. So I'll give my HOD, maybe HOD should wrap it up. So let other people ask their questions, then I will give it to HOD to ask afterwards. All right, 1, 2, and then the HOD. 3? All right, the first person.
Yeah, thank you very much, Ma, for that wonderful talk. Machine learning was part of what...
Mike is afraid of your voice.
Okay, machine learning was part of what you talked about. And to my little understanding, machine learning is an aspect of AI, right? That uses the machine based on data set to make prediction even without being explicitly programmed, that it can think on its own. So I want to know the application of that machine learning to this malaria and pregnancy. Was there a system built whereby the machine could on its own, make prediction, like tell us this will be the number of infection after this time? So was there any system like that built in this particular model? Thank you very much.
Did you get his question? All right.
Thank you. So the ARIMA actually did some forecasting. No, because it's just for like 2 years forecast. And so from the prediction, we could see the number of possible cases in the next 2 years from one of the results that were displayed. So after analyzing the data, we generated the pattern over time, and then we made a 2-year, we made some forecasts from between now and the next 2 years. So you can see how we have a 95% confidence interval of that forecast, that within this range, the cases of malaria in this region can rise to so amount. So that was where Arima did our forecast of possible cases. I don't know if I answered your question. Yes, immediately it's able to understand the data using the past historical data. Then it should be able to now do prediction or forecast of future cases. Thank you.
Okay, thank you. Next person.
Thank you very much for the presentation. My question is, which aspect of this presentation did which aspect of this presentation did you use machine learning? Because based on my understanding, I understand that there is what we call a time series analysis, and part of time series analysis is all this Harima, Hehar, Ramar, and Co. And then in terms of machine learning application, there is what we call the SVM, which can also be used to implement what you have used Harima to do. Then I want to know where machine learning is being applied in this particular work. And then how did you fit the Harima model such that you can assume that it is actually a machine learning model? That's actually what where I need clarification.
Thank you, sir. All right, so this work actually worked on time series. Yes, so Harima was used, and yes. So here, after carrying out the studying the pattern with Harima, we were able to choose a best model based on the Akake information criteria parameter, the one that has the lowest value. Then after that, we carried out some other statistical tests on the chosen model to see if it's captured the necessary information by looking at checking the test for normality checks, the check for histodrastic effects, and then we carried out to check the autocorrelations. So at the end of the day, we discovered that most of the results were above the p-value, expected p-value, the significance level. And that was what gave us a push to move on with this chosen model, that okay, it's fair enough. Although most of them display strong seasonality, and that has nothing to do with the goodness or fitness of the model, but it shows that malaria transmission has a strong relationship with seasonality, which requires further study on studying the seasonality inherent in malaria transmission data.
In a nutshell, you have used a time series model, not machine learning.
A time series model.
Thank you, ma'am.
But time series is like the initial stage. Yes, because there must be pre-processing. So this work was just majorly on the pre-processing. Okay. Yes. Then yes, but Harima played the role of machine learning here, but it's not really for like I said, just to forecast. We've not started prediction. Yes, we just carried out forecast after analyzing, pre-processing the data. Thank you. Thank you, sir.
Well, thank you, presenter. I'm indeed delighted to hear from you your presentation based on machine learning. However, you should be a little bit careful when you are in the midst of mathematician and statistician. What you did concerning time series, you can't do prediction accurately without studying the series. Thank God you answer my colleague there accurately at the end of the day, because he was actually trying to tell you you do not use machine learning. Actually, you use machine learning when you are talking about this time series. Thank you for clearing that. But actually, where I'm going, it has to do with your choice of data. Case study, let me use that one. You base it region by region. Well, you find that based on my own exposure to some regions in the country, you find out that if you have looked into the area of level of education consideration, it goes a long way. That's what I wanted this region. The region that have been captured adequately, look at their level of education. You find out it's higher than the others. Thank you.
Thank you, sir. Yes, just to respond to that, this was more of a pre-processing. So by the time we want to do prediction or further analysis, we can now bring in some factors. We have socioeconomic factors, of which level of education will come in, the lifestyle and culture of the people there, how they like I said before, that some of them don't come out for antenatal care until their pregnancy is advanced. It's because of their level of education or exposure. So those factors can really be brought in when we want to do proper further analysis. But at this level, we just try to look at the data, the raw data that was brought, that okay, what has been the trend before now? So for future work, yes, we are going to consider these factors and then see how it affected the cases we found in those regions. Thank you, sir.
All right, thank you so much. Please let's appreciate Mrs. Oniyelu for that beautiful presentation. I wouldn't know if online participants have questions. Please let's check our online platforms to be sure that we don't have questions waiting for us on those platforms. Media, please help us check that. Okay, we'll talk about that generally. Okay, so now, for this morning session, we have looked at different things this morning so that we can catch up with what we were supposed to do yesterday. We couldn't finish up with what we were supposed to do yesterday. So on this occasion, we just finished up with yesterday's activities. So can we clap ourselves as we are going to start today's program? The things that are booked for today. So that means that we really need to work together to achieve everything that we want to do today. And somebody was saying that, okay, please give enough time for Anton. It's usual. It's normal. Everybody wants to do Anton. But you also did one Anton this morning and you enjoyed it, isn't it? You enjoyed the modeling class, isn't it? You were able to put some models together. Good. You are becoming a modeler, isn't it? That's good. Let's clap ourselves. Let's clap ourselves. We are becoming modelers gradually. But in any case, you cannot become a modeler in 2 days. But at least you are seeing you are enjoying it. Okay, that's a very beautiful one. Now, yesterday, I told us that there are key foundations that must be laid. And you will see that whatever foundation is laid by our dear prof is what the rest of us are coming to build on. I don't know if you notice, if you observe that he lays the foundation of what we are supposed to do. And we just come in, pick on each of those things, try to exhibit it for us to see the things that he has talked about, how it is done. So, again, to start today's events, let's at least take one session let's Prof start us off again. Once it's done, we go for our tea break. Now, but I can see some of us, it seems we didn't sleep in the night. Now, Prof told us one time, he said, if you sit down for more than, how many minutes now? More than 1 hour, it's equivalent to you smoking how many sticks of cigarettes? 6 sticks. Oh boy. Please, don't let us do that. Let's rise up. Let's try to stretch. We need to stretch. There's this thing Prof used to teach us. So he will teach us again. I'll hand over the mic to him so that he can teach us. You know how to stretch. Prof said, sometimes when you see somebody that you think the person is big, fitness is not about smallness or bigness. Prof, I'm right, sir. So some people are small, but they are not fit. Yes, because, they don't do exercise. But my prof does exercise. When you see him doing exercise, I don't know if I can match him. Please, let's Prof teach us.
So you go.
All right. All right. With this level of calorie burns, I'm sure that we'll be active. I used to have somebody, after she's done doing this kind of thing, then she will sit down and prepare very good cold milk and tea and take. And then we are told that the calorie you have burnt and the one you are replacing is even more. So when you are going for tea break, don't take more than 1 cup. Is that okay? All right, please join me to welcome Prof as he takes us through this session. You are welcome, Prof, sir.
Okay, so good morning. How many minutes do I have? 50. So 11:21. This is 11:21 to 12:11, right? 12:11. Okay. Good morning, everyone. Yeah. So we have spent a day, and then we have started a new day. I want to ask, especially from some of us who are just having this kind of experience the first time. Now, can 1 or 2 persons tell me since yesterday the level of your infectiousness? Whether you have been infected, are you at a low level or medium, or you are highly infected? Because some people came to meet me yesterday after the class that they would like to come and they don't want to leave it there. They want to come for mentoring because they have seen the need that they need this tool. So I want to know from one or two or three persons, what is, have you been provoked to step into higher level, to know more and all of that? Because 2 days is not enough. 2 days is just for us to give you like a glimpse. And then from there, it's like a charge to make you see the need, and then from there you want to take it up. So I don't know if there are one or two persons who want to say one or two things since we have been here the last 24 hours. Yes? Yes, from that side. Anyone who has been
To
infected?
what extent have you been motivated to
Have you been infected?
what we have been
Yeah.
doing? Have you been infected?
Yeah.
Yes.
So whether you are partially infected or you are already, there are some infections that are very severe.
Are you severely infected with modeling already?
So, let's hear from some of us. Like from that side, anybody? Yes, sir. You can give the mic to him. Olagbami, please, can you hand over the mic to that man?
So thank you, sir, for the opportunity to be here. So actually, when I saw the flyer and I was trying to apply, I thought of, okay, I'm from chemistry, and this is about mathematical modeling of infectious diseases.
Can you?
Okay. I said when I saw the flyer, so I was skeptical to apply for this symposium. So I was thinking, I'm a chemist by training.
Okay.
So, and this is all about infectious diseases modeling.
Yes.
So I was thinking, what do I stand to gain by coming here? So I just, I applied and I was considered to be here. So during the presentation yesterday, so I saw someone presenting something. He mentioned something about steady state, equilibrium state, and from there I connected to it because in chemistry also we have what we call the steady state approximation, the pre-equilibrium approximation, and something like that. So I now see that my coming here is not in vain, that there is connection between mathematical modeling and chemistry.
Okay.
So I'm happy to be here, sir.
Okay, thank you very much. Now, to respond to that comment, now we have had students done some project on chemical kinetics, modeling of chemical kinetics, chemostasis. You understand? So, like I said, modeling is not about epidemiology only or infectious disease only, but we have peak interest in that area, and then we have pitched tents there because of the need in our nation. But it's not as if, it's the same mathematical tools that we need. Whether you are in chemistry or you are in physics or engineering, we have the maths to respond to any system. But the question is, now we shift our eyes from there, and then our focus is mainly on infectious disease because we have a lot of problem here in that area now, and then we are trying to respond to that. So now, we have a lot of mathematics that can respond to a lot of chemistry laws. Yes, like what somebody was saying yesterday about mass action. Mass action principle is in chemistry, and the idea was the one we use when it comes to transmission of disease from one non-infectious person to an infectious person. So that kind of thing, we have a lot of them, and modeling can. Now, one good thing about it for chemistry is because now there is an aspect we call computational chemistry. Now, which is being, which the strength of it is in modeling, because a lot of some chemists, especially who are in sub-Saharan Africa, where you don't have access to a lot of equipment, that's an area you can pitch your tent, and you can do a lot of work once you have data, and then you can do a lot of computational chemistry analysis and all of that with computer and data stuff, and you have a long way to go with that. So I think it's not a waste. Thank you. Yes, anyone from this place, this column? Yeah. Anybody who want to say something in this column? Yes, thank you.
Yeah, thank you very much, sir, for this symposium. I would say I'm already infected, but I've become more infected.
Oh, you are already infected. Good. And
I'm
you have
now
become more infected.
Yes,
Right. I'm very happy to hear that.
Yeah, I also worked on malaria for my master's project.
Can you increase the volume?
Okay, I said I worked on malaria too for my master's project. I cited one of your work on malaria, and
okay.
I'm coming today to see you in person.
Okay.
I'm really excited.
Okay.
And
Thank you.
I've gotten some things because there was a way I was thinking of mathematical modeling, but
Before.
my eyes have been open to
Wow.
some certain things.
Great.
And I believe that there are more things for me to still gain. And I will say thank you very much for this.
Okay,
opportunity.
thank you for that comment. Now, like I said yesterday, that one of the reasons why we are organizing some of this meeting, last month we were at Ekiti State's Ministry of Health, training people who are in public health, like giving them what it is about, like meeting the town and the gown, The town and the gown. The gown is academia. The town are the people in the industry. Like there is a parallel line between the two of us. And at this 21st century, we are in the knowledge economy. Now, in the knowledge economy, knowledge will spread all over the world. It has just started. It's going to be an exponential growth. Now, some of us you are in academics, you have lost your focus. We were discussing that some few days ago. You are in academics because in Nigeria they are telling you that, there is no money, a lot of things, and then you are there, you are teaching in about 5 places. It's because we have not seen a vision of what is coming ahead. Now this is time to sit down with research, because academic consists of 4 things. You have teaching. This is teaching. He's the smallest guy here. Now, teaching, research, community development, and innovation. Now, if you are at every level you are, whether you are a lecturer 1 or lecturer 2, assistant lecturer, or you are a professor, there is what we call progression. Now, so that progression, I see it as the stages at which an egg grows, from egg to larva to pupa to adult and all of that. Now, at every level you are, whether you are egg, if you remain as egg, you are at risk. If you remain as egg, when an egg remains an egg, you are at risk of getting spoiled and destroyed. That egg is supposed to move to what? To larva. If it fails, like every egg that comes out of the mother chicken, that comes out that did not stay under the incubation, what happens to that egg? It becomes rotten. So there must be a progression. So whether you are at larva stage or you are at pupa stage or you are adult stage in your academics, there must be a task for progression. Now, if there is no task for progression, when it comes to research, you are going to be cut off in the 21st century revolution. You'll be there, but in the long run, you are just there as dead, though living. You are dead, though living. So we have a lot of professors, a lot of doctors who are just title conscious, but no man too conscious. Now, this is time that there's going to be a flood as we go on. A flood of knowledge that is going to flush short people away. They may still be in the academia, but they will not be relevant. I want to beg you, if you are here, that if there's any other thing, because you see now, when I see people going out there, jackpot to other countries, I just laugh, because some of us who have gone and come back, several, in fact, it's just recently that I got tired of traveling because I saw that there are a lot of things to do in my country to help people. Now, let me tell you something, that there are thousands of problems in Nigeria to solve with mathematics. But the challenge is that there are few people who are reading. People don't read again. If you send anything to the third one you are talking about, all those professors there, you think they read anything? They don't read anything. They don't read anything. People don't read again. Ask yourself, when last have you opened a textbook and read chapter 1, 2, 3 to 4? Since when you get your PhD? People don't read again. And you see now, everything, every secret is kept in the books. So when you don't read, then you are out of the game. You don't get to know anything, and then what happens? Look at it now. What you will see is that because the people outside, they know what is going on. Do you know what they do? Now, there is a long trip of people from Western world, from China. They are entering. Many of you don't follow migration data. They are entering Nigeria because they are entering African countries because they have seen what Africans don't see in their country. So Africa are doing what? They are going there for 21st century slavery. They go there, right? They say, some of you, you say you want to do, what's it called? Caregiver. You go to UK, you do caregiver. Now, when you go to UK, you are doing caregiver. How many of the British people do you see doing caregiver? You won't see them doing that. It's either you are from Asia, you're from Africa, that they are doing that kind of work. Now, what are they using you to do? Because, do you know that the population pyramid of the Western world, in terms of the young population, is decreasing? Maybe you don't know. Most of them are not giving birth to children again. So what is happening now is that now they are using our own children to make up their own living standard. So that when your children are working, you go there, your children are sent, or maybe your brother is sending you dollars and all of those nonsense, is under slavery. And then their own economy is being helped, and then they are coming here to do a lot of, before we got the Bill Amendagate grants, now what they do is that, because I work with some groups, what they do is that they are the one BMGF are giving those grants. So they collect the grants and model for us in Nigeria. Until Africa fought against that you cannot be outside the country and be modeling for a country you don't know anything about. There's no way your model. So most of the time, those models are not correct. Because they are not here to see what is going on. As I am here now, I can easily I've called the malaria program manager of Ekiti State that we had a program with last month. I've called him this morning. I said, I need certain this, I need that. He will easily give me. A white man cannot easily come like that, and I know their needs. I know how to meet their needs. So we have a lot of problem here, pollution problem, environmental problem, socioeconomic problem, climatic change problem, disease problem. When I talk about disease, both infectious and non-infectious, we have them. So and then when it comes to finance, you also have a lot of problem. For you to use mathematics or statistics to solve, if you position yourself well. So if you are busy roaming about, you are roaming about here and there, instead of you to sit down and get something done and make life better, solve problem. The world is meant for people who are ready to solve problems. Solve problem. When you solve problem, then money will come. Are you getting what I'm talking about? When you solve problem, you said your salary is 500,000 as a professor. When you solve problem, you don't know when they pay salary. You don't know whether they pay salary or not. That's not what I'm thinking about. Are you getting what I'm saying now? It's not about moving from one place to the other. Use your brain to think and solve the problem. Get with the people. If you don't know how to do it, go and meet people who are doing it and learn how to do it. Because if you don't solve the problem, do you know that at the end of the day, you yourself can be distracted. You can lose focus and be pursuing other things. So once people become PhD holder now, they don't read again. I have many of them everywhere. They don't read again. People don't read again. They can be publishing papers, but call them to come and do anything. They can't. I will call some, come and present something. They will run. Because in my center, if you come and say you are a PhD holder, we will ask you, go to the front and present. Those things you say you have been writing, come and present it. Let some young guys, MSc, PhD who are here, who are standing here to help in how. They will ask you questions. If you can respond to it, then we know that you have the stuff. So it's not about talking about it. In Nigeria, we do more of the talk, but less action. And that is why a white man don't respect us. They don't respect us because there are less action, but many talks. And it's also in the academia. I've seen it a lot. And that is why there is no respect for Nigeria. So we need to wake up. We need to start thinking of how to solve our problem with ourselves. There are a lot. If you remove mathematics from machine learning, everything about machine learning is scattered. We are doing it. Remove maths from it. So a lot of mathematicians don't even know enough maths to solve Nigerian problem. So that's why if you sit down with the maths, there are millions of things that you can use maths to do. Maths and statistics. Millions. You build your algorithm. Once you have the software skills, and you need software skill plus the mathematics and the statistics, then you're on the go. There is nowhere you cannot rise to. So I want to challenge us this morning. Young guys who are here, don't wait and saying that, oh, I want to go and be selling cement. And then because when you are supposed to be doing your research, teaching your students, you are selling cement somewhere, you have a cement shop, you have already lost focus. You are already lost focus. If you give time and concentration on your research, what a man who is doing cement cannot get in 1 year, you get it in 1 month. Yes, I can tell you the truth. In 1 month, with just using your brain and sitting down to reason. There are things in research. I was telling some people a few days ago, I said the most valuable resource now is data, not oil. The most valuable resource all over the world is data. So if you can know about modeling and you know about how to connect modeling with data, you're on the go. And that's why in the center, we focus on both modeling and data analytics. Because that's where the world is going on. That's where the world is going. The world is quantitative. All the Facebook, social media, what are they doing? They are collecting your data. WhatsApp, they are collecting your data. All of the social medias, Instagram, they are collecting your data. So why will you sit down and fold your hands and waste away when there are many opportunities for us in the nation to solve African problem? So this is my first challenge for all this morning, and we all need to wake up and do something. Now, in our center, we have opportunities for visiting scholar, internship, regular associateship, and all of that. Now, some people may want to say they want to learn modeling, fine. You want to learn analytics, data analytics. Because there's no area you are, whether you are in social science, you are in biology, you are in physics, you are collecting data. But a lot of people have those data, they are just looking at it like mirror. They don't know what to do with the data. How do you use your data to inform policy? Because the strength of policy is in the data. Now, you can't make policy with a theoretical model. It's not possible. You make policy with a model that you feed data, and you inform policymaker that this is what your model is saying given the data that you have. So I think that's the way to go in the 21st century. I want to challenge us once again this morning. Now, yesterday, I was talking about the dynamic models and how much complexity we need. And I talked about the statistical models that start from univariate to multivariate to generalized linear model. The complexity increases. So this morning I'm going to start with the dynamic models, which somebody was asking yesterday. Those are the mechanistic models that can help you to see into the intricacies, the underlying mechanism of that disease. So, and then for us to do that, the least out of those models are the deterministic models, which are continuous or discrete. Now they start as the least out of the model. You can see that it said increasing complexity and realism as we go down. Now, deterministic models, which is where so many people are working on. Deterministic models, continuous, so they can be continuous. The continuous are the ordinary differential equation, delayed differential, partial differential equation, and all of that. And then the discrete are the difference equation, which we can use for finite number of time. And then it moves then from the complexity increase, and we need to put some, for these there are no randomness. Everything is the same given in the initial condition. And then the stochastic models are given to stochastic fluctuations. So they respond to some randomness, they involve some randomness, both in the structure of the model in terms of the variables and also in terms of some of the parameters. And then we have the metapopulation or network model, with this with spatial heterogeneity of infectious disease. When you want to study disease from location to location. There's a work we are doing now on Lassa fever in Ondo State and Edo State. That's spatial metapopulation of Lassa fever in Ondo and Edo States. So we are trying to use mathematical model and some time series modeling and forecasting to explore that kind of system. So this metapopulation has to do with how people move from one location to the other. Like yesterday, capturing people's movements in terms of how they also transmit disease. Then agent-based model was the one I said yesterday that has to do with individual models, that you will have to develop an exponential model for each person. I mean, each person in the population will be captured. And they have attributes, and you allocate some certain attributes in terms of infection status, vaccination status, and all of that into them. Now, but one thing you realize here is that there is an increasing complexity and realism as we go down. Now, what happens is, as models become, as you need to make prediction with models, because there are two major things about modeling. It's either you are trying to gain insight or you are trying to predict. Now, gaining insight in a model will only require a simple model. But to predict, to use your modeling to predict, you need high-dimensionally complex models to respond to that. And that's why, as we go on, complexity is increasing. But there is another issue with that. The disadvantage is that as we go on, it's decreasing in tractability. You try and track some of these, it becomes more complex. And, like Mogo Judy was presenting this morning, and as he was presenting, something came to my heart that, okay, now he was figuring out the fact that when you put a mosquito, when you use an LLIN, there are two things LLIN can do, two protection. Now, if the net is still okay, the mesh between the nets, the mesh, there's a grid or mesh between the nets. So if they are still intact, the mosquito cannot penetrate. So it has protection in terms of entering. Then, if the mosquito also, if the chemical on the net is still okay, the chemical has what? Some killing effect, right? Killing effect due to the insecticide that is on the net. Now, the what's it called? The mosquito can also die naturally. So you see that in the mosquito compartment, you are having two deaths. That means death due to the insecticide that is on the LLI hen, and then death due to what? The natural immunity. Now, all of those that you are bringing is making, though is realistic, but it's making the model to be more complex. Are you getting me now? Because you are already having two deaths for the mosquito class. Death due to insecticide and death due to what? Natural situation for the mosquito. So as you increase the parameters, the model is becoming more complex. Now, how good is my model? A good model should be parsimonious. What do I mean by parsimonious? Simple, but not so simple. That's what Albert Einstein said. Albert Einstein said, a good model should be parsimonious. Simple, but not so simple. Not so simple. In the sense that simple, but not so simple as to remove detailed, realistic biology. Now, you see, your model is as good as your biology. Now, if the biology or the pathogenesis of that disease is not understood, you are not responding to any situation in terms of realistic situation. Now, how can you say you are modeling malaria and the only thing you have is you have now somebody was modeling Onco and then he has this and then this and then this. Now this is susceptible human population. I mean, this human population. This is for him. This is the black fly population. The black fly is the vector, which is Similium spp. Now, what happened is, now this kind of system, when I saw it, it's representing a vector-borne disease, but this does not respond to onco because this is something you can find in a normal infectious disease modeling textbook that somebody can solve. Now, because now this compartment now, I can use it for dengue. I can use this for dengue. I can use this for any vector-borne disease. I can use it for dengue. I can use it for Zika virus. I can use it for malaria. I can use it for which other disease? Chikungunya, Chagas disease, and all of that. You can use it for them, Chagas. Do you understand? Now, what make a model of dengue to be different from a model of malaria is the data. The data. Now, because I can use this model to capture so many vector-borne disease at a simple level, basic level. Because this model does not contain some detail. It's too general. Do you understand? It's too general because it has two compartments for human, which means that people only go from susceptible to infected. And this does not really picture what malaria represents in the population. Because if you are going to model malaria, you need to also have the asymptomatic. That's the biology of malaria, especially for Nigeria. Now, conform to data. A good model should be conformable to data. Now, if you model something, and actually in mathematics, you can, if you don't have a data, you can model. Do you understand? You can model, but your model will be too general. It's not specific to a particular place. So it's not speaking to a particular problem. You are just doing some academic exercise, so to say. Now you can publish that, but that does not inform policy. Because nobody uses a theoretical, like now, let me give you an instance. You develop a model, you put a LLIN, you put a vaccination, you put all those things, and you didn't use any data, and then you are saying that your model, we predicted that about 25 people are going to be averted. Where? Where? In which location? Because the model does not have any data. So in which location? So the question the policymaker will ask you is that this model that you have done, is it responding to a particular location? Which location are you doing it for? And if you are saying you are doing it for Ondo State, which data did you make use of? So we need to be literate, even especially, and that's why in this meeting we are bringing together people who are public health and people who are mathematicians. Now I'm going to be showing you some few things later Everybody have his own wish list, but in this 21st century, we must combine the wish list together for us to solve the problem. Right? So that's why we bring people who are mathematicians and then public health people together to be able to see from different views to solve this problem of disease in our nation. So there must be a balance between conformity to model and parsimony. So balance conformity to data and parsimony. In the sense that if your model is too simple, then it may be difficult for you to conform that model to data. Because it will have lost so many details. Details that the data may have captured that you didn't capture. Let's take for instance now, you have a model, just a normal model, that does not, like, it's just a normal model. It does not involve any particular function. Now, and then the data is showing that, your data is showing maybe cases of malaria in Ondo State. Is showing seasonality. You are seeing seasonality. I'm not saying oscillation. No. Seasonality is systematic peak of infection at certain time of the year. Like maybe at every time in January, you are always seeing a peak. Maybe January 2015, you saw a peak. January 2016, that same peak. January 2017, that same peak. January 2018, that same peak in January. It means that there is seasonality in that disease. Now, and your model is just normal. Now, it means that if you want to model this kind of system, you need to put a seasonal function in your model so that when you are fitting your model to data, it will show that seasonal pattern to be able to capture what you are seeing in the historical data. So we need to get some of these things clear so that you are not just doing things that is not conventionally acceptable. So a good model should be easily generalizable. What do we mean by that? Now, if I pick that model, what it means is that if I pick that model, I can use it in another place and it's going to give the same representation. If I pick this model and use it in this place, it's going to help to determine, to solve the problem and make prediction. So, and then a good model should be able, you validate the model. You need to validate. So what is validation? Validation has to do with being able to match your model with your data. This is the data. Sorry. This is the data. And then this is the model. Something like that. Just doing something. Now, what is happening here is that you are trying to capture the trend in the data with the model. You are trying to capture what is going on in the data, the behavior of the data given the model, and then in the course of doing that, there are two things that can happen. That is what we call overfitting. Overfitting is you are trying to capture that pattern, but you are capturing it so much that it's actually the same shape with the data. It may be very dangerous. So it must have been that you have done some underlying jomo. So, and then you can make prediction. Now, I was saying yesterday as well on the issue of infectious disease that when you are modeling a microparasite, we have microparasites. Microparasites are virus, bacteria, protozoan, fungi, and prions. Prions are toxic proteins. They cause diseases like CJK, all those diseases, food poisoning, and all that. Now, microparasitic disease. What do you model when you are doing microparasitic? You model infectious status. And that's why microparasitic disease are maybe like malaria, it's a microparasitic disease. Cholera, most of the disease we model in Nigeria, they are microparasitic disease. So what we focus is infectious status of the individual or the population. Now, but for microparasitic disease, which are helminths, arthropods, who are with that has a lot of things to do with worms, ascaris, lubricoids, tapeworms, and all of that. Now, you cannot model a macroparasitic disease the way you model a microparasitic. You cannot model onchocerciasis or schistosomiasis. Schistosomiasis is a vector-borne disease, right? Right? You are not answering, no. Some of us are not sure. Schistosomiasis is a vector-borne disease, right? But you cannot model, it's a vector-borne disease, but it's a macroparasitic disease. Malaria is a vector-borne disease, but it's a microparasitic disease. So what you are looking for in malaria, in modeling of malaria, is not what we are looking for in modeling of chisto. So in modeling of chisto, we are looking for the bodies of the worm. The worm body is what is the focus. Now, whether it is low worm body, or it is medium worm body, or it is high worm body. One of my students is going to be talking on STH. So one of them talked about FGS yesterday, female genital schistosomiasis. Now, these are NTDs. These are neglected tropical disease. STH is soil-transmitted helminths. This is a neglected tropical disease, and their model does not follow the same way, like microparasitic disease. So when it presents, you are going to see what I'm talking about. So now, our operational definition of a microparasitic is indeed an organism whose population biology can, to a sensible force approximation, be described by some compartmental model. That's a macroparasitic disease. Now, macroparasitic disease may be thought as those having no direct reproduction within the definitive host, which embraces most parasitic helminths and arthropods. So, macroparasitic diseases are typically larger and have much longer generation times than microparasites. Their lifespan is longer. In fact, the lifespan of macroparasites can be as long as the life of the host, the definitive host, which is human. Sometimes a worm, you see somebody is dying at 80, he's still having the worm he has been having when he was a child in his body. The worm is as old as him and can stay long in your body. So what we are looking at is the worm body. So the person may not die, but is having some disability, whether in the brain or in his eyes or some part of his organs. And you know, yesterday we were talking about FGS. One of the risks of FGS is HIV. Because of the lesions. There's a lesions, there are inflammation that are being caused in the genital system that can make that person to be more susceptible or vulnerable to HIV than somebody who does not have FGS. And even cancer, cervical cancer. If a woman is having FGS and is not treated, she is at risk of having cervical cancer. So, and some of the things we were discussing yesterday. Now, I want to quickly move away from that. So, but before I move, I said, for microparasite, the various factors characterizing the interaction, the egg output, that's what we are talking about, the egg output per female parasite, pathogenic effect on the host, evocation of an immune response in the host, parasite death rates, and so on and so forth, can all depend on the number of parasites in a given host. So mathematically, this means that the relatively simple compartmental models must be replaced by more complicated models which take full account of the distribution of parasites among the hosts. Let me move away before they give me paper. Now, there are model that I said yesterday: ordinary differential equation, partial differential equation, stochastic, agent-based, machine learning algorithms, network models. But one thing I was trying to say was, even if you are doing machine learning, if you don't understand the mathematics of machine learning, then you don't have a strong foundation. There's a mathematics of machine learning. Now, once you remove the maths, you remove the statistics from machine learning, everything collapses. Yes. Because it's the maths that make up the machine learning. Now, what time do I have left? 10 minutes. Okay. So, now, formulating a model for a particular problem is a trade-off between the important and often conflicting elements, and that's what we call accuracy, transparency, and flexibility. Now, this part I want to discuss, very, very important. Now, accuracy is what? The ability to reproduce the observed data and reliably predict future dynamics is clearly vital, but whether a qualitative or quantitative fit is necessary depends on the details of the problem. Now, accuracy has to do with reality, complexity. If a model is going to be accurate, it has to be complex. Highly complex, to be able to predict future dynamics or projection or project it. So it means that you have to put a lot of elements or components in the model parameters that has to do with the biology. You know, I was saying yesterday that now how do we bring model into disease? Now, you are seeing a particular behavior. Do you have a mathematical function to represent that behavior? That's where you start from. Now, and that's why if the depth of your mass is very weak, there is a certain level you can't grow in modeling, in mathematical modeling. You can't come to a particular, yes, I'm telling you the truth this morning. Now, if your math is weak, if you don't have a good foundation, I'm talking about, like most people who are developing, a lot of people are coming to modeling now, even medical doctor that, I trained, one of these guys is there. I was talking to him yesterday. I consult for Nigerian Malaria Fellowship, Malaria Modeling Fellowship. And I've trained medical doctors. Some of them are my students, who are doing modeling and all that. But I let them know that, when it comes to mathematical modeling, if I remove the mathematics, then there's nothing you can do again, even as a medical doctor. Because the mathematics of the modeling is with the mathematicians. So it's only to the level I show you that you can actually grow. Now, some of us who were trained in a place where, like in the University of Ibadan, I was trained to be a pure and applied mathematician. And that is helping me a lot because I did a lot of functional analysis, strong functional. And now, if you are going to travel far in modeling, you need a very strong functional base. Yes, if you don't know functional, then you can't travel far. You will be doing simple models that cannot do much. Yes, because there are functions, there are situations in life that respond to certain mathematical functions. Are you getting what I'm saying now? So if you don't understand them, you will just be looking. In fact, at certain time when you want to do some inferencing, there are certain inferencing that are based on strong probability functions. You need to understand the measure space, measurable space and all of that for you to come to that. I was doing something on stochastic models and I have to enter measure to do some measure theory. Yeah, measure theory. But you know, the challenge is now being able to, now those things that were in maths, they were actually, the mathematician actually started from the real world, and then they bring real world into abstract. So it's the abstract some of us are reading. Now those abstract, now the people who are now reading abstract, to now bring it from abstract to real world, that's where the challenge comes. So, but if you can sit down and read and get all these things again, it will help you to advance your modeling. Now, qualitative fits can be may be sufficient to gain insights, can you see, into the dynamics of an infectious disease. But a good quantitative fit is generally necessary if the model is used to advise on control policies. Now, I was talking about qualitative analysis yesterday and quantitative. Now, a qualitative analysis may be only sufficient to gain insight, just to understand the dynamics. You are doing a theoretical work, just to understand the dynamics, especially at the beginning of the disease. Now, that cannot make you get to give advice to control policies. People who are doing public health officers, you can't do that if you don't know the quantitative aspects. So what we are doing now is both qualitative and quantitative to be able to respond to people in the health sectors. Accuracy generally improves with increasing model complexity of the inclusion of more heterogeneities and relevant biological detail. So you include many heterogeneities, many things like demographic heterogeneity, spatial heterogeneity, temporal heterogeneity, and all of that. Because for you to come up with a model that will be used to advise policymaker, it has to be complex and involve a lot of details. Now, clearly, the visibility of model complexity is compromised by computational power, the mechanistic understanding of the disease natural history, and the availability of necessary parameters. Those are the challenge. Now, if you don't have good computers, that's why you want to do modeling. You don't do modeling by just theoretically writing things. You have to have strong computers that can run simulations within real time. And then you also need the mechanistic understanding of the disease natural history, the one I've been saying. You need to understand the natural history of the disease. You need to understand the availability of necessary parameters. Consequently, accuracy of any model is always limited because of these three things. Now, transparency is another trade-off. This comes from being able to understand either analytically or more often numerically how the various model components influence dynamics and interact. So the transparency has to do with, you want to understand what is going on, what's the mathematical analysis behind this work, which is basic. Basic. So this is usually achieved by successively adding or removing components and building upon general intuition from simpler models. So you are modifying, you are trying to add this, you are putting this. So as the number of model components increases, it becomes more difficult to assess the role of each component and its interaction with the whole. So it becomes difficult. You don't even know which of these parameters or some of these components that is really, really driving the disease dynamics. Once the model parameters are becoming many. So it's difficult to be able to track. Now, transparency, therefore, often in direct opposition to accuracy. So in transparency, you are not actually looking for complexity. You are looking to understand, to gain insight, with using numerical analysis to validate your analytical results. Flexibility measures the ease with which the model can be adapted to new situations. This is vital. If the model is to evaluate control policies, you can easily put some new, just like yesterday we developed a normal model that does not have control, and then we put in control today to evaluate control policies and then to predict future disease levels. Now, most mechanistic models, such as those within this course, are based on well-understood disease transmission principles. They are based on well-understood disease transmission principles. Now, when you are doing mechanistic models, one thing that makes it very strong is that you are capturing transmission. Transmission in the sense that people are having contacts and disease transmission is taking place. Right? That is mechanistic models. Now, and are therefore highly flexible, whereas black box, you see, mechanistic models are flexible in the sense that you can customize your own. That's why we have different kind of models. Somebody developed this model. This person is looking at another question and is addressing something and is still using the same, an advancement of what you have done. They are flexible. But for black box model, like time series models, black box time series models, such as neural network, like those one that Dolapo presented today, they are that may be able to accurately reproduce a given time series of reported cases are less amenable to modification. They are less amenable to modification. Now, models have two distinct roles, prediction and understanding, which are related to the model properties of accuracy and transparency. Prediction has to do with accuracy. Understanding has to do with transparency, and therefore can often be in conflict with each other. So we usually require a high degree of accuracy for any predictive model. High degree of accuracy. Whereas transparency is a more important quality of models used to improve our understanding. So prediction is the most obvious use of models. The most obvious use of model is prediction. Now, it requires that the model is as accurate as possible and therefore includes all of the known complexities and population level heterogeneities. Oh. I have no time. Let me quickly say some parts, maybe another time, because I have a lot of things I wanted to discuss, but there's no problem. We still have another meeting another time somewhere. So let me say a few things here. Now, so an epidemiological modeler requires a wide arsenal of tools. I want to quickly tell us, you want to venture into mathematical modeling, what are those things you need? And techniques in addition to an understanding of disease behavior. Now, some of us have very good knowledge, the biology, especially people who are from public health, you know the biology and the ability. Now, apart from ability to construct models, that's another skill you need to get to know. If you know the biology, how do I learn to construct model? If I see a particular scenario, can I develop a model around it? Not only in infectious disease, it could be about pollution. Can I see a scenario in terms of air pollution in Ondo State and develop a model that captures that scenario and then be able to come up with something? Now, here we give a brief summary of potentially useful additional techniques and disciplines and point to general materials that provide an introduction to the matter. In much of this course, we go about modeling by first considering the underlying assumptions about the process. So we look at the assumptions because every model is limited by its assumption. Involve and how this scale the number of affected and susceptible individuals. We then proceed to express these assumptions. We go and we express them. Before you say you are writing your model, you list out your assumptions, and then in terms of mathematical equations, which are then analyzed. So you go for the analysis. Then after that, the actual process of analysis usually involves computing the solution numerically. So you do the analysis in terms of mathematical analysis, and you validate the analysis using numerical computing. Because models are often analytically intractable. They are complex, nonlinear systems. Now, a variety of off-the-shelf software, what do I mean by the shelf software? May be used to solve the differential equation. All the shelf software are MATLAB, MathCAD, Mathematica, Maple. They are proprietary software. You cannot easily purchase them without money in dollars. Now, these ones, but there are also some software that are open source, which we are encouraging people, like the one we are using to teach you yesterday on R. So, numerous scientific computing packages also permit quite sophisticated models such as Mathematica, Maple, R, Python, MathCAD, and all that. And then our personal preference is to carry out nearly all model analysis in code written in high-level computing like R. In my center, we are very close to R. Now, you need a sound knowledge of statistics. A sound knowledge of statistics is obviously an essential asset for you to do modeling, allowing us to link models with available data and providing a framework for analyzing the results of model simulation. Now, statistics therefore has three main purposes in epidemiological modeling. One, it allows us to analyze the data, any data that are available, and to use this information to drive parameters and associated confidence interval. And that's why our center is modeling, mathematical modeling, and what? And data analytics, because of the statistics. That's where the idea came from. It's highly important. Now, you want to analyze an associated confidence interval for our model. Second, statistics will provide a powerful set of tools to compare model outputs with available data, with the general aim of showing that the model is a good fit. Finally, statistics can be used to compare the result of multiple model simulation and to elucidate the differences between them. This is particularly important if the model are stochastic. You want to check the difference between models. Statistics itself is a very diverse subject area, and no single publication could possibly cover the entire discipline. Now, statistics, however, statistics in theory and practice by Robert Lupton or introduction statistics by Ronald, these are some of the texts you can use for statistics, provide a good introduction to the basic statistics. And whereas Markov chain, that's MCMC by Danny Gammerman, is a suitable primer for the rapidly expanding field of MCMC and Bayesian analysis. So, and then when we are lucky enough to have a long-term case reporting data for a particular infection, as in the case of measles in England and Wales, then techniques from time series analysis. That's why we are also venturing into that, time series analysis model, because we have a longitudinal data or panel data. And then, although technically part of the discipline of statistics, time series analysis is a subject area in its own right with many powerful tools that can be used to examine longitudinal data and to extract meaningful patterns, and such as periodic oscillations or density dependence or periodicity, like the one I showed you the other time, this one, seasonality. Now, there are books, time series analysis by James Hamilton, 1994, nonlinear time series analysis, a dynamical system approach by Overton, review the range of techniques and possible applications. Now, for a more model-based perspective, both dynamical system and numerical techniques play important roles. Can you see that? Dynamical systems and numerical techniques for a more model-based perspective. So we have discussed many things now. Apart from the software tools, you need the statistics, you need the time series where you're having a longitudinal data or panel data, and then you need dynamical system tools or numerical techniques. Dynamical system tools, especially for model people who are in mathematics, Now, which provides an understanding of model behavior in terms of fixed points. We are talking of fixed point yesterday. Dynamical system. Provide understanding of model behavior in terms of fixed point, attractors, and stability. Attractors and stability. Now, some basic knowledge of the subject area has been assumed throughout this work, and then but participants seeking a more detailed knowledge could consult Introduction to Modern Theory of Statistics, Dynamical System, and all these books the likes. Now, numerical techniques are often important. The models that are developed are unlikely to be analytically tractable. So therefore, it is important that we can compute the solution accurately and rapidly. So numerical research series of books give a wide range of techniques and sample routines in a variety of programming language that can be readily used. So throughout this course, the vast majority of differential equation models has been integrated using the fourth order longitudinal scheme, which provides a good balance between accuracy and simplicity. Stochastic models and partial differential equation models have their own particular model of simulation that are discussed at the relevant, like for what's it called? For stochastic model, we have the Euler-Nakayama method. For PDE, you have finite difference. You have finite difference, and you have a finite difference scheme and some other ones that I cannot remember now. Now, yeah. So many other subject area impinge into upon epidemiological modeling. There are parallels between ecology and epidemiology, with many ecological concepts possessing a counterpart in epidemiological theory, like metapopulation, as I said yesterday. It's an ecological principle, but it's being used in epidemiology. Now, in addition, if we are interested in wildlife disease, like people in vet medicine, people who are doing vet medicine, who are interested in zoonotic disease. Now, then a solid ecological model, knowledge and model of the host dynamics in the absence of infection is a necessary starting point. Over the past few years, molecular and genetic techniques have provided the epidemiologists with unparalleled insight to dynamics of infection within the host organism and how the pathogen operates. So we also use genetical data, molecular data, to alongside with surveillance data. Yes, there is also that in the recent time. Nowadays, it is common to study infection where the genome of the causative agent has been fully sequenced and annotated. So an understanding of immunology and genetics is also vital if you want to be a good modeler. If epidemiology modelers are to take advantage of this growing body of knowledge that underpins the basic infection behavior. Finally, we are often interested in how infectious disease relate to humans and human activity. In such circumstances, it is often possible to separate disease control from issues of economics and social sciences and also environmental change. That's climate. Because of the recent time, there's a global change. It's having effect on malaria. Now, lastly, public health epidemiologists wish list during an epidemic. What do they want to see? The public health from mathematical modelers. Now, the public health authority will be looking for answers to the following questions. These are some, not all. Estimation of reproduction number and other epidemiological thresholds. Maybe like herd immunity. That's what an epidemiologist want to see. Now, they also want to see qualitative nature of the disease spread. Now, yesterday somebody was presenting something on method of calculating reproduction number. But that's just one method. You can use the model. You can also use the data to do that. We don't have the time to do that here. Apart from the model, you have a data, you can get your hand note from your data as well, using some probability distribution. It's very possible. Now, qualitative nature of disease spread. Spreading speed. They want to know that. What's the speed of the spread? When peak is attained, at what time are we going to get to the peak? They want mathematicians to tell us that. You know you are having an oscillation. So when is the oscillation going to get to the peak? So you need the knowledge of physics. T is equal to 2 pi over LG or something like that. I can't remember the formula very well again. That's the period. Now, when epidemic when epidemic will die, when will it die out? Are there multiple waves phenomenon? Just like during COVID, there were multiple waves. The first wave, second wave, third wave, and all of that, and we are seeing different kind of strains. Now, they want to see estimation of disease burden, expected number of infections, and disease-induced deaths. In terms of how many people are we expecting to have the infection in 2 weeks' time, in 1 year time, in 2 years' time. Time series can do that for us. Now, expected number of hospitalization. How many people are going to be hospitalized? With the way the disease is going, evaluation of control strategies, targeted strategies, herd immunity, cost of intervention, optimal allocation of limited resources. These are things people in public health want to know from your model. Now, public health also wants you to answer, how severe will the epidemic be? So you are like a modeler is like a prophet who is there sitting down with his mathematics to predict or to forecast or to project what will happen in the long run. Now, total number of infected people who may require medical care, maximum number of infected people at any given time. How long will the disease last? Are we going to continue to sit down at home? Just like COVID-19, we sat down at home and we are washing our hands. Now, when will it peak? What will be its time course? How effective will quarantine or vaccination be? What quantity of vaccine or antiviral drugs do we need to stockpile? What are the effective measures to contain, to control, to eradicate an epidemic disease or endemic disease? Partial answer can be obtained using a variety of approaches. Now, mathematical modeling has proven to be an important tool in assisting public health authorities to make informed decisions. This brings us to the obvious question: why is mathematical modeling of infectious disease useful? I'm going to come back to this when I finish this talk now. Part of the answer is that traditional method using experimental and statistical approach may not be adequate for various reasons. I don't have the time to discuss the various reasons now. Now, mathematical wish list, characterize qualitative dynamics, system of differential equation, existence and asymptotic stability of solutions, type of solution, equilibria, periodic, stability, local versus global, condition for persistence and elimination, that's uniform persistence, and elimination of disease, especially for disease like malaria. These are things that mathematics can want to see in modeling. Now, determine types of bifurcation, forward, backward, and which is transcritical. Does the system exhibit chaotic dynamics? Analysis require the use of dynamical systems, theories, and techniques like non-function theory, comparison theorem, perturbation theory, positive matrices, Poincaré, Berdiksen theorem, center manifold theory, etc. The goal is here, develop new mathematical theories and techniques for handling large systems of differential equation. It's not just about writing what people have been doing in terms of the classical analysis. At the end of classical analysis, what do you do? What do you do in this work that you didn't know before? And that's what will make your work to be publishable. So the question I want to ask us as I round off is, why is mathematical modeling of disease useful? Thank you.
Thank you, Prof. That was a load there. A question has been posed. So I believe that we are thinking about it. Prof ended this class giving us the public health wish list and the mathematical wish list. I don't know if you are like me thinking, where do these two wish lists intersect or cross? Does the wish list of the mathematical person Does it respond to the wish list of the epidemiological guys? All right. So, in 5 minutes, can we allow questions, and then we go for our tea break? So let's ask questions. So maybe when we, because there's going to be a time for interaction, interactive session. Yeah, somebody may help us pen this. Now, I have just raised a concern. Yeah, so let's ask a question. Let's ask our question. Because, like I've told us, Prof is here to lay some foundation that many of us will come up after to start looking at. Once we come from tea break now, we'll be going into a session where Prof was talking sometimes about, oh, this is a certain concept that you want to capture. What function do you use to respond to that? So the next speaker will be particularly looking at some of those functions as the functions we use in mathematics, and you think that you just use them, and you see them all around, but the usefulness as it comes into, infectious disease modeling. So one of us will look into that, and then we'll see the practicality of it. Simple functions that you can interact with. All right. Okay, so a hand was up for question. Mama, are you still interested in the question? You should be. All right. Then our HOD is also there. A request. Okay. Please, let's give the...
Thank you, Prof. My request is that how can you make this material available for us?
Okay.
Thank you.
We'll talk about it.
Okay, later.
Yeah,
Thank you.
Yeah. Sometimes, even the people online too have been asking, and we'll talk about it. All right. Of course, we know you are here for the work, for the symposium, and you want to go back with something. So we'll talk about it as Prof said. All right. So let's get the question.
My question is, at what point does mathematical models result to higher differential equations, be it ordinary
or the mic is
partial?
afraid of your voice?
At what point? At what point does our model result in higher order differential equations?
Higher order differential equation, not...
Be it partial or ordinary, or there cannot be any form. There cannot be an existence of
At
a model.
what point does our model result to higher order differential equation? All right, let me allow Prof to respond.
Okay, yeah. So, like, what the focus is that it depends on the system you are looking at. You understand? For many epidemiological issues, problem of infectious disease, they don't usually tend to that kind of system. But maybe for fluid dynamics, you want to understand the dynamics of fluid, or maybe like climate change problem, you can have such kind of models. You understand? So where you also have to put some boundary value conditions and all that. But for many epidemiological model, because most PD models or higher order, like order 2, orders that may not really fit in because of the nature of the behavior of infectious disease. So, but for other systems, you could use that like climate, like even while you are reading, you understand that this is what this thing is tending towards.
Thank you so much, Prof, for the answer given already. So at this point, we will be proceeding to take our tea break. Are we happy? We are not happy. It's more mathematics and tea break. So for those of us who want more mathematics without the tea break, don't worry, we are here together. And I'm sure that everybody will now be happy. All right, but I know they want tea break. Okay, so let's go for tea break. While going for tea break, please let's wear our tags. You know, we are in the academic environment, you understand? So we don't know who and who do we serve before we get to realize that our participants are not being attended to. Please, let's put on our tags so that you can be attended to. Nobody else takes what should be yours. All right, so let's rise. We'll come back by 1 o'clock to continue the next session. So let's go for a tea break. And as I've always told you, if you are not interested, just take the break. You can leave I can take the tea on your behalf. You can go for the break if you don't want the tea on your behalf. All right, please, let's go out. Let's stretch. It's time to stretch. It's time to take tea break. It's time to interact with colleagues. It's time to network, to know people, meet with people. You could not meet with many people yesterday. Meet with people. People are doing great things here. Meet with them. Fresh air outside. Get to talk to people. Get to relieve ourselves of the mathematical modeling. By 1 o'clock, we'll return. People, shall we begin to? Let's stand up. We are still sitting. I can see many people sitting. You like sitting? Stand up a bit, walk around, go take tea break. It helps. It helps blood circulation. It helps blood circulation. Please don't just sit down. Stretch out. Get to talk to people. Get to take fresh air. All right. Dockers, stand up. You are still with your laptop. Stand up. Stand up. Stand up. Stretch out. Sitting for too long is not good. Let's go and take our tea break, everybody.
A lot.
It's no matter of the sending. Hello, mail. So then,
All right, can we start coming in? The tea break is over. Can we start coming in, please? Please, let's start coming in. All right, we are all welcome back from our tea break. Hope we enjoyed the tea and the break. All right, so please let's settle down. So coming next, we have a very key important session coming next on board. So we'll be having a session on mathematical foundations for infectious disease modeling. Please, one house, please.
All right, thank you so much. I'm happy that we are cooperating. It's 1 o'clock, it's past 1 already. So that we can finish to time, it's very important that we actually cooperate, work together, so that we return when we ask us to return, and then we can finish the time we want us to finish. So for this next section, before our lunch, we have a few things to do before lunch. So we are going to be looking at something I told you Prof was talking about, and one of us will be exhibiting that on mathematical foundation for infectious disease modeling. All right, and then after that, we go on to do hands-on on R, on infectious disease modeling and analytics. So the use of R, we do our hands-on. And then finally, somebody is also going to be showing his work, exhibiting a work on soil-transmitted emithiasis. And then we go for lunch. So when we return from lunch, Prof is going to be taking us through a session on how to write modeling paper. That is very important for us because over time we have seen, like Prof was saying, that the way people do modeling in Nigeria. So we will show step by step, approach of doing that. And then we are going to be having an interactive session, which is going to be the last session for the day. And then, so we close afterwards. So, in essence, we are having how many sessions to go? One, mathematical foundation for infectious disease modeling. The hands-on. Then there's going to be work exhibited on soil transmitted emethiasis, how to write modeling paper, then interactive session. So we're having 5 sessions to go for today. All right. I believe that you enjoy the rest of the other programs as you have enjoyed the previous ones. So permit me to call the next presenter, Mr. Samuel Abidemi Oshikoya, to present Mathematical Foundation for Infectious Disease Modeling. Please join me to welcome Mr. Sam. All right.
All right, so good afternoon, everybody. So it's a privilege to stand before you to take this particular course, Mathematical Foundation for Infectious Disease Modeling. This aspect is very, very important, reason being that just like Prof has taken us through some lectures, you want to model a particular infectious disease. One, having understood the biology of the disease, now you also need to understand the peculiar mathematical functions that are useful to capture some aspects of the disease dynamics. So I will begin with something simple, then from there we proceed. So this are just the overview. We are going to look at simple equations. We'll look at function of time, exponential functions, disease transmission matrices, basic calculus, and also we'll look at differential equations. So now, let's start with equation of a straight line. So these are basic stuff that, if not properly understood or, Prof said something the other time that the mathematics actually started from the real world. So from the real world, we go into abstraction. But some of the problem we do have now is how to now go from abstraction back to the real world. So here we have equation of a straight line, very simple, y equals to mt plus c, where m is the gradient of the line and c is the constant value at which the line crosses the vertical y-axis when x is equal to 0. So now, I'll be showing all some of these functions and also paint a kind of example so that we can see how these things are related and how these things can be used in modeling disease dynamics. So from what we can see on the screen, you can see that in infectious modeling, the mosquito biting rate can be modeled as a linear function. So for this one now, this is just an angle of modeling malaria dynamics. We are trying to model malaria, and one of the key aspects of that transmission is the biting rate of the mosquito. So there are several authors that have represented the mosquito biting rate. Just like I told you earlier, I said there are aspects of the disease dynamics that you want to capture with the aid of some functions. So here now we have a straight line, and here we have some authors who have represented the mosquito biting rate as a linear function. And some of them, they did this in order to make the complex, to make the model not too complex, especially for the sake of doing maybe model analysis. So from what we can see here, we could see that we have the beta of B equals to beta max minus B max minus beta mean as a function of B. Okay, yeah. Okay. All right. Oh, thank you. So now from what we can see here now, we can see this is just a representation. This is just a representation of the mosquito biting rate. This one is just it is expressed as a linear function. Then, apart from that, we also have function of time. The equation y equals to ft is a typical example of a function of time. And when coming up with maybe disease dynamics, parameters are very, very important in that you use those parameters to explain the All right. Yeah, thank you. Okay. All right. So now, yeah. So let me just quickly. Sorry, that was the screen. So here now, just like I said earlier, we have the beta max is the maximum mosquito biting rate. The maximum mosquito biting rate. Then we have the B there, proportion of bed net usage, and we have the beta mean, which is the minimum mosquito biting rate. So now, what you are trying to do here now is that you are trying to represent the mosquito biting rate as a function of the LLIN usage. Reason being that in order to reduce transmission, there are several control interventions that are put in place in order to reduce transmission of malaria. And what you just have here now tries to capture that aspect. That is, expressing the biting rate as a function of the LLIN usage. From this now, you can check that, okay, if we vary the value of the mosquito net usage, all right, what is going to happen to the biting rate? So this particular linear function is just used to capture that. Are we together? Are we together? All right. This one here, yeah, that's just like a kind of omission. That should be, this is the same thing as this one as is here. That's a kind of mistake. Yeah, sure. All right. Okay. Now, so let me just take it this way. Now we look at function of time. So simply put, what we have here is just a function of time. So now I was trying to explain the other time that parameters are key part of mathematical models, in that those parameters are used to explain the dynamics of the disease. Now, some of these parameters can either be constant or can be time dependent. And the parameters being either constant or time dependent determines the kind of differential equations you are going to have. Maybe it is going to be autonomous model or a non-autonomous model. So, for instance, now this is just a simple model equation. So the parameters beta and gamma are constant parameters. So in this particular case, these two parameters are constant parameters, and thus the model is an autonomous model. So we need to understand there are times you want to see some variation depending on the disease you are trying to capture. Prof said the other time that one thing is very, very important: understanding the biology of the disease. So if part of the biology of the disease, maybe you are able to see maybe a kind of seasonal variation, and you want to capture that seasonal variation, you may not be able to use a constant parameter for that because there are variations. So you may want to make your parameters to become time dependent to be able to capture that seasonal variation. All right, so next we have time dependent parameters. So for instance now, just like I said, I'll be explaining these things and be giving us practical examples so that you'll be able to see what I'm saying. So seasonality of malaria represents systematic peaks of malaria cases observed annually in our home case. So now we have several factors that contribute to the disease transmission dynamics, that is malaria transmission dynamics. And now seasonal variation can be integrated into the mosquito biting rate. If you look at the previous biting rate I showed us, it was just modeled as just a linear function, isn't it? But that has a limitation. It has a limitation because that may not be able to capture the seasonality that you observed in the data. Now you want to capture the seasonality that you observed in the data. Then we can come up with something like this. This is just one of the basics function that you can come up with. It's not other function in order to capture the seasonal variation observed in the data. Now, and it's very important for me to say that your data determines how you go about your modeling. There are patterns and quite a number of things that you have observed in the data, and now you want to come up with a mathematical model that is able to mimic the patterns you have seen in the data. So, for instance, now, if we observed in our malaria, for instance, our malaria cases, for instance, is usually seasonal. So, and now you want to capture the biting rate in terms of what we have here. This B naught here just represents the mean biting rate. What you have here now, which is this BA, it only represents the amplitude of this northern function. And here you have the period. For instance, now in Nigeria, the period is just 12 months. If you are using a monthly data, if it is a yearly data, which is just 1 year, you can just go on to use 2pi. Then we have the time, and we have the phi, which is the phase shift. Now, one thing we need to note here is this. So we can see now that this biting rate is modeled as a function of time. Right? Right? Please, are we together? Is modeled as a function of time. So now, compared to the previous one I showed you, if you are to integrate this now into your model, it makes your model to become non-autonomous because your biting rate is explicitly dependent on time t. So then we move to exponential functions. Exponential functions are very, very important in modeling, and just like I said earlier, it all depends on what are your observations. Having read the biology of the disease, what are the things you have observed? What are the processes that you want to capture with the aid of mathematical functions? So, for instance, now we have here that the constant E, which is called Euler number, is a mathematical constant. It has many useful properties and is used extensively in mathematics and in the biology and physical sciences. It is formally defined as this. This one is just a simple definition, just a definition of the Euler number. So if we raise it to the power of t, then we have this particular function here, or this particular equation. So next we have, similarly, if e is raised to the power of product of any two numbers, e.g., e raised to the power kt, we can also express this as this. And it does not only take maybe positive exponent, it can also take negative exponent. And these two things you are seeing here, they have their applications in maybe disease dynamics. Let's take, for instance, maybe like Mr. Sheon took us the other time, one of my colleagues, when he took us LLIN, we're talking about maybe the effectiveness of LLIN, the utilization of LLIN, and all of that. So now, there are times you may want to consider, maybe in the transmission you are considering, maybe there are some aspects of it that declines over time or that grow over time. So now you want to capture that. To capture decay or growth, one of the functions you can use are exponential function. Are we together? So we can make use of exponential function. Reason being that, just like Prof said the other time, there are things observed in the real world. Now you want to look for mathematical function that is able to capture what is observed in the real world, so that by the time you are coming out with your result, it becomes something meaningful and that is also reliable, which is very, very important for policy making. All right, so here are is just a plot of exponential minus kt plotted for different value of k, plotted for different value of k. You can see here we have sharp decline. The green also have a somewhat sharp decline, but here we have a slow decline. Are we together? So this is just like a decay. So what we have here now is just like a decay function. So let's take, for instance, you want to model a particular system, and part of the system, maybe the part of the processes of that system involves maybe decay of a part of it, and you want to capture that, you can use the exponential function to actually capture that. But you also need to also understand the decay you are talking about. Is it something that decline or that decay very fast, or something that goes slowly or is it something that decay slowly? So I don't know. Somebody is saying online that the host is muted, so maybe that should come and check. Somebody just send that message now that the host is muted. All right, so away from there, we have logarithms. This is just a definition of the all right, so now we have the logarithms. These are also just functions. Depending on what you are trying to do, then you can use it to also model an aspect of the disease transmission. Now, we want to look at use of exponential functions. Use of exponential functions. Exponential functions are widely used in infectious disease modeling to describe the spread of diseases, decay of immunity. Are you seeing that now? Growth and decay. Spread of diseases, decay of immunity, or growth or decline of populations, like vectors, which are like maybe in the case of malaria, like mosquito. Then we have hosts or pathogens. So let's take for instance now we have the immune response and waning immunity. So we want to look at immune response and the waning immunity. Immunity to certain infections, e.g. malaria or COVID-19, may wane exponentially over time because there is no permanent immunity against malaria. So the immunity wanes over time. And now you may be interested in capturing the waning immunity over time. So for instance, the level of antibodies may decay. We know that the antibodies are responsible to fight against the parasites. So we have A of t equals to A naught exponential minus kt, where A of t is the antibody concentration as time t, and gamma is the decay rate of immunity. So now you are trying to explain the decay rate of the immunity. So now you are able to come up with a function like this to explain that process, to capture that process, and that can be integrated into your model if that is part of your interest in coming up with the model to explain the transmission dynamics of that disease. Then here we have disease transmission. Early in an outbreak, when most of the population is susceptible, the number of infections grow exponentially. Reason being that at that point in time, there is no control measure. Maybe control interventions have not been deployed. So there's a kind of exponential growth of the disease. For example, in the population of susceptible, if each infected individuals infect R naught others over a generation time t, the infectious count grows approximately as I of t equals to I naught exponential RT, where R is the exponential growth rate. And this one just represents the initial number of people that are infected as time t equal to 0 when the disease begins. So, key insight, exponential growth reflects the rapid rise in cases in an uncontrolled outbreak. So these are just functions that we are used to, but they're very, very important to model disease transmission dynamics. So here now we have modeling waning IRS effectiveness. These are just examples of the exponential function that as I've explained earlier. So IRS is the indoor residual spray that is used to kill adult mosquitoes. They are sprayed on the wall, and this is due to the fact that when mosquitoes take blood, they want to rest on the wall. So this behavior of the mosquito made people to come up with IRS that, okay, if we can put the chemical on the wall, while the mosquito is resting on the wall, the chemical kills the mosquito such that they are not able to go to oviposit. Then, so we have the Gaussian function. An example of exponential function can be used to model the waning effectiveness of IRS. So let's take, for instance, now maybe you want to look at the effect of IRS in controlling malaria transmission dynamics. And now you want to incorporate the IRS not as a constant, because it is known that the RS is not always constant over the years. So you want to capture the decline that is observed in the RS. Maybe because the chemical that wanes and all of that, then this is the general gunshot function is expressed as this, where A is the peak value of the function, and in the light of IRS, it represents maximum effectiveness of IRS at T equals to B. And this B now may be 0. This T may be 0. That is when you first just implemented the use of the IRS. So at the beginning stage. So the B there may be equal to 0. So we have the time at which the peak effectiveness occurs. And that is B equal to 0. Because when you spray it, its ability to kill mosquito is very high. But over time, the chemical begins to wane, and its effectiveness also begins to reduce. And now you want to capture this in your model. So you can do that with the aid of Gaussian function. And also, we have C controls the spread of the function, how quickly the effectiveness wanes over time, and T, time since IRS application. So we can see here now that this particular IRS effectiveness also model as a exponential function is also a function of time. So if you integrate this into your model, it makes your model non-autonomous. It's not constant. Reason being that if you take this as constant, you may not really be able to see what is going on in the transmission dynamics, because you have kept some things constant. But as you make it a function of time, you're able to see some of the changes and their impact on the malaria transmission dynamics. And this is not just limited to malaria alone. There may be other diseases also that you also want to look at the impact or the effect of a particular control intervention on the transmission dynamics of that particular disease. So here is just a pictorial, a visualization of what I was trying to say. Now, you have model, you have captured the waning effectiveness of IRS. So this is just a plot, as you can see. So if at the beginning it is 100%, this is at time T equal to 0, the effectiveness of IRS is 100%. But over time, what happens? It wanes. Are we getting it now? So you are using that function to capture this behavior as observed on the IRS effectiveness. So now we have other important functions, which is the logistic growth model. So we have logistic growth model describes a situation where the growth of a population or process is initially exponential but slows as it approaches a limiting factor known as the carrying capacity. So now, this is something observed in reality, right? This is something observed in reality, but now you want to represent it with the aid of mathematical equation because you want to capture that aspect. Let's take, for instance, now, you can use this one now maybe to capture, maybe let's say the immature mosquitoes. Reason being that maybe space available for them to breed, to come out as adults is limited. Are you getting it now? So it's limited. So that limitation now, when you consider, okay, the availability of the immature mosquitoes or the availability of the human population, then with limited resources, you want to capture that process, then you can make use of the logistic growth, model. As you can see, this type of growth is common in infectious disease modeling, where the spread of population expansion is constrained by factors like finite resources, competition, or behavioral changes. So this is just like solution to what we have in that place. So, and that brings me to matrices. So as simple as it is, matrices are very, very important in to get some properties, to get some results after you have come up with your mathematical models. So matrices are mathematical tools used to represent systems with multiple interacting components. In infectious disease modeling, matrices allow us to, one, represent transmission dynamics, study interaction between host vectors and also environment. So, and what we have here are just some operations on matrices. We have the addition, we have the inverse of the matrix, we have the multiplication, and all of that. So here we just have definition of the eigenvalues and eigenvectors. So given a square matrix A, an eigenvalue lambda and eigenvector V satisfy this particular equation. So these are just like just basic mathematical theories. Eigenvalues are found by solving this particular equation, with which we get the characteristics equation for the particular matrix. So then we have, so this is just an example. Given this matrix, we can compute the characteristics equation by finding the determinant of this, where this I represents the identity matrix, then lambda is what you are going to use to represent the characteristics equation, and that's going to represent your eigenvalues. So going through all of this, the eigenvalue is what we can see here, and with that you can proceed to get the eigenvector by substituting when the lambda is equal to 5 and when the lambda is equal to the second one. And these are very, very important, because when you come up, for example, now you're with your mathematical model and you want to find a key aspect in epidemiology, which is called reproduction number, the matrices become something that cannot be neglected, because obtaining that reproduction number depends heavily on some matrix operations. All right, so we have uses of matrices. I've just talked about this. So this is a typical example now of this is just a simple model, although the initial conditions are not stated here. To check the local stability of the disease-free equilibrium, first we need to compute the DFE, which is disease-free equilibrium of the model. And how do you do that? To calculate the disease-free equilibrium, you just set each of these equations, you set them to be 0. You set them to be equal to 0, and with that, you'll be able to get your disease-free equilibrium. So this is done by setting each of the equation in 3 to 0, and with that, you are going to get this. So one of the things that we can do with matrices is to find the Jacobian of the matrix. So I'm using 1 stone to kill 2 birds. So here, what we have here now is to find the Jacobian matrix, we compute the partial derivatives of each equation with respect to S, I, and R. What does that mean? If you have to go up here now, this is a particular equation. All right. So now represent this one. Let's say this one is F, this one is G, this one is H. So you have to find the partial derivative of this F with respect to S, I, and R. And with that, you'll be able to get the Jacobian matrix. You also do the same thing for this also. You differentiate it. If this one is G, you differentiate that G with respect to X, I, and R. And you also do the same for this. And with that, you'll be able to get the Jacobian matrix that is stated here. Then substituting the value at the disease-free equilibrium, you have the Jacobian matrix at the disease-free equilibrium, because you can see our X is equal to S star, but I and R, they are equal to what? They are equal to what? They are equal to what? 0. So if you substitute those ones here, you arrive at this. But don't forget, I've taken us through computing characteristic equation of a matrix. So the next thing you want to do is you want to find the characteristic equation of this Jacobian matrix evaluated at the disease-free equilibrium, and we came up with this. Now, why are we doing this? We are doing this because there are some properties about the model that you want to understand. Are we together? There are some properties about that disease that you want to understand with the aid of the model. And that's what brought us to this. So we might have been doing Jacobian matrix just for fun, but it is relevant to get some properties in our disease model. So here, if you do all of that, then you get the characteristic equation to be equal to this. And we know what this means. That when lambda square times this equal to 0, is that this becomes 0 or this become 0, isn't it? We have this to be equal to 0 or this one become 0. And what is the interpretation of that? So now, like what Prof said the other time, we have moved from reality to abstraction. Now from abstraction, we want to go back to reality. We have found the Jacobian matrix and all of that. So the question that is of interest to epidemiologists or public health professionals is, so what can we infer from what you have obtained? So from here now we have, when lambda is equal to 0, this eigenvalue corresponds to the fact that one of the solutions is steady or unchanged. But we also have this to be equal to, so this one says that the stability of the disease-free equilibrium depends on this eigenvalue. For instance, if this is less than 0, then the disease-free equilibrium is stable. Otherwise, the DFE is unstable. So And then these are just to explain matrices, what they can be used to do. Then we have basic calculus that has to do with derivative of functions. These are very, very important for us to come up with our mathematical models. Then we have differential equations, which is one of the major tools that modeling heavily rely on. And they are of two types. We have ordinary differential equations, partial differential equations. Somebody was asking the other time, at what point do we know if, and I really appreciate Paul for explaining that. It's not just about coming up with anyhow model. As Prof has emphasized over and over, what is most important first is what is the biology of the disease and what aspect of mathematics is able to capture what you have read from the biology of that disease. So we have system of ordinary differential equations. So these are the definitions. So this is just a typical example of a system of ordinary differential equations. So the x, y, z are the dependent variables. The a, b, c, d are the constant parameters. So, but what we have here now is just like a general equation. It's just a general system of equations. If you solve this and you get the answer, it's going to be general. It's not particular to anything. But when you include initial condition, as you can see in this place, then it becomes a particular problem. And it's always emphasized that whenever you're coming up with a mathematical model, it's very important that you state the initial or realistic initial conditions. That's when it becomes a problem to be solved. Then, differential equations can be used to predict outbreak dynamics, evaluating the effect of interventions, and also understanding herd immunity. So the major thing we need to note here is that very, very important to us, just like Prof said the other time, it's very important for you to understand functions in mathematics, because there are processes in the disease transmission dynamics that you want to capture with the aid of this mathematical function. Using a wrong mathematical function may lead to erroneous results. And don't forget, coming up with mathematical model to explain disease transmission dynamics, we are actually dealing with people's lives. And that is why you need to really be careful the kind of functions you use in order to inform or drive policy. And at this junction, I'm going to say thank you for listening.
Yeah, thank you, Mr. Oshikoya, for that beautiful presentation, driving all the way from linear equations down to system of differential equations, as we have seen. And like he said from beginning, that each of these functions are important, and we need to know how to use them, where to put them, when we understand the process that we want to model. All right, he has presented. I wouldn't know if there are one or two questions for him before we go to the next thing on the agenda. All right, so I give number 1. Any other person? Okay, so let's give him the mic. Okay, for the sake of people online, please help us, for our media, help us check in case there are questions online. Let's find out.
Thank you for the presentation. I want to know the relationship between X and X star, because I saw you use X star, I star, R like that. So I want to.
The S star, I star, R star is just to represent the value of those state variables after you have set the equation to be equal to 0. It's just a representation, just designation. When you have set the values of those state variables at equilibrium, simply put. All right.
All right. Thank you so much. Please let's appreciate Mr. Samuel for the job done.